Ladies and gentlemen, we are on a 1-minute warning, please. A 1-minute warning. We will go live at 10 a.m, so please just take note. Well, good morning, ladies and gentlemen. It is 10 o'clock on Monday, the 29th of January 2024, and this is the first meeting of this calendar year of 2024. There is, as ever, a lot going on within working groups and the volume of supporting activity, and I would ask the district and borough chairs to make a judgment call as to how much of the things that you see and these disseminators you share with your own committees on a local level. Particularly in terms of one of today's items, primary care access, because I am sure that will be of interest to many of the people at a local level. I would just make one rider with that, which is the aim isn't that they re-scrutinise what has been scrutinised in this committee, and I know that local members will be really keen to get into the detail and the data about their own specific areas, but that is not the purpose. The purpose is to make sure that the good work that is done within this committee is more widely publicised and is more widely available for other councillors to disseminate locally. I would also just in passing like to say particularly the quality of the primary care GP access report is of note. I've chaired this committee for roughly the past 4 years and been on it for 4 years prior to that. I think it's one of the best reports in terms of the quality of the information, not necessarily what's in it, but the quality of the information that we have seen, and I think that is just something we should note and thank those people who were involved with that for the input. So in terms of this morning's agenda, I'd just like to say a few words. Firstly, in relation to the Chief Executive of UH&M, Tracy Bullock, who has announced that after 5 years as Chief Executive, she is to step down in June. These Chief Exec roles are significant roles. Tracy is the boss of 16,000 employees and also has the pressure of a busy regional trauma centre and has managed remarkably with all the things that have been thrown at her, particularly during the COVID years. These trusts are enormously difficult to manage, and I personally would like to pay tribute to the work of Tracy and wish her all the best going forwards. And I'm sure that committee would echo that. I'm not seeing many nods, but maybe we'll get there. I know it's Monday morning early, but I attended the in-person board meeting of the Integrated Care System in December, where a decision in principle was taken to close the George Bryant Centre in Tamworth following the fire there back in February 2019, subject to the outcome of the Midlands Partnership Foundation Trust Board meeting, who's responsible for the building and the operation of it. This committee has previously decided that that decision was not a significant change to services and has monitored the consultation and reviewed the impact. The MPFT board meeting met at the end of last week and noted the decision and have agreed some further monitoring for information. There was an inspection by the CQC of the wards of the older peoples with mental health issues, the wards of Midlands Partnership Foundation Trust at the end of November last year, and the CQC's rating is that they continue to be good, and equally that the Trust's rating continues to be good. Just in passing, the Integrated Care Hubs Working Group, there is a business case that is being developed for 2 of the 4 hospital sites, which by necessity may make the contribution of some of the members of that working group less relevant or less timely. And as a result, I would encourage members of that working group to maybe review that decision in terms of whether we change the scope of the working group, and second of all, the membership of the working group. I think committee will take lead from the chair of that working group, which is Richard Cox. Talking of working groups, I think we were offered last year a visit to see the West Midlands Ambulance Service Control Room when they attended committee at the end of last year. And I'm going to suggest that we take up that offer for a small number of us, those interested, but at the same stage to set up a working group to look at the processes around the setting up of defibrillators on the national system. Second of all, to look at the processes around making sure that members of the public, when they ring into the control room, do get allocated to the nearest defibrillator. And thirdly, to make sure that we look at the processes around the training of staff, ensuring that members of the public do get allocated to the nearest defibrillator. I'm aware of a number of concerns from the community, particularly in the Staffordshire Moorlands area, and I think that a working group is the appropriate way of delving into the detail in relation to that. Let's get on with this morning's agenda. This is Staffordshire's Health and Care Overview and Scrutiny Committee. I'm your chair, County Councillor Jeremy Pert. Welcome to all our guests. I don't know whether we're going to have some virtually as well, but welcome to our guests, and welcome to all our councillors and committee members. May I remind committee that it is being broadcast live, and those who want to watch it back, the session is being recorded and can be found on the County Council's website. So if members of your committees, councillors at a local level, at a district or borough level, want to watch the proceedings, they can do so. And in fact, I think it's one of the most watched committees within the County Council. It is being beamed live for people to be involved, and will cut off 20 minutes after the equipment has stopped. All voting committee members are in person, and there is a variety of in-person and virtual guests. Could I ask our guests to accept that members have read and digested the papers provided, and restrict their comments to 5 or 10 minutes as there is a packed agenda. And I would like just to juggle the agenda, but we'll cover that as we go. And I'd also ask our guests to focus on tangible outcomes for the residents of Staffordshire. So, first item is apologies. I think we've had apologies from Councillor John Jones, who is substituted by Barbara Hughes, who I've not seen yet, but I'm sure she will join us shortly. And we should wish John a speedy recovery and expect to see him back in this chamber in time for our March meeting. Other apologies?
Good morning, Chairman. I've also received apologies from Councillors Chapman, Councillor Wilkes and Councillor Halton.
Thank you, Zach. Declarations of Good
morning, Chairman. And my apologies, I have to leave at 11:30 for a meeting I can't get out of. Thank you, Chairman.
That's noted, and we have to juggle the agenda because we have some of our guests who need to similarly likewise leave us. Thank you, Phil. So on to declarations of interest. Do we have any declarations of interest relevant to this morning's agenda, please? Anne Edgeler.
Thank you very much, Chairman, and good morning, everyone. Yes, I'm Partner Governor to the Midland Partnership Foundation Trust.
Thank you, Anne. Noted. Bernard.
Good morning, everyone. I'm the local authority appointed Governor to UHDB.
You are. Thank you. Any other? David.
And I'm a Staff Governor at UHDB, like Bernard, and also a physiotherapist at UHDB.
Thank you. Understand that. I don't think there'll be anything particularly that will come across, but if there is, no doubt you will let us know. Thank you. So, can I just confirm for the minutes that we're quorate? Yeah. Thank you. Okay. So, item number 3, minutes. I know this is a while back, so can we approve the minutes of the meeting held on the 20th of November? I've got a couple of minor changes, if you'll bear with me. Page 5. The penultimate paragraph that starts "the committee were advised." The penultimate line of that paragraph should say "data." It's the data that was collected, not the date that was collected. On page 7, on the first bullet, I think the second line should read off-site rather than off-sire. And I think those are the corrections we just need to pick up. Anyone got anything else? Otherwise, are we happy to agree that they are a true record of our last meeting for those of us who were there? Okay, that's unanimous. Let's do that. I'm reliably informed that all actions have been picked up and members will have seen the response from the Chief Exec of the Environment Agency. So, item 4, approve the minutes of November the 27th. Again, I would just like to pick up a couple of things. Page 13, first bullet. Whilst it is a root cause analysis, I think it's root with a double O. Page 13. You've not got page numbers, that's helpful. I'll give you my notes.
Okay, thank you.
The bullet which starts induction of labour, I think labour should probably be a small L, otherwise that sounds like it might be political. In terms of the bullet which starts voice partnership, 2/3 of the way down, it's talking about processes to work, and I think the missing word is with mothers, and we will get that added if members are so minded. And those are the changes I've got. Keith.
Thank you, Chair. Yeah, I just wanted to point out within the minutes on item 4, I did bring up the concerns from the District Council about the defibrillator issues that have been occurring within the Staffordshire Moorlands. Of course, you have now responded to that concern with the idea of setting up a working group, which you announced just a moment ago. But I would like the reference still to be in those minutes as an ongoing issue that we've now had some occurrence with, and I know that you've also had a few letters coming back from them as well. So can I just thank you for your work on that, and if you can just include them in the minutes, I'd very much appreciate it. Thank you.
It was certainly very much part of the conversation, and you've been a champion for your community in that area on that issue, and we certainly did have that conversation. So with everyone's permission, we will add that to the minutes. Okay, thank you. Otherwise, are we happy to approve the minutes as a true and accurate record? Thank you. Okay, let's move on to the meat and drink of why we're here. Paul, are we in your hands, or are we in Tracy's hands, or Sarah's? Where are we going?
Going to pass over to colleagues, if that's all right. So I think Tracy's going to lead on the dental.
Thank you. I should have just said that we're just going to rejig the agenda slightly and pick up the dental first, followed by GP access, followed by social prescribing. Okay, thank you. We're with you.
Thank you, Chair. Good morning, everyone. My name is Tracy Cox. I'm the Associate Director of Primary Care for the ICB. I'm here today to present the Primary Care Dental Overview paper. So in terms of dental, you will be aware, as well as optometry and pharmacy, that we now have delegated commissioning responsibility for dental, pharmacy and optometry as at April 2023. And we have been working really closely with our colleagues from NHS England, who are now Office of the West Midlands, who work on behalf of the 6 West Midlands ICBs to deliver our delegated responsibilities. What we've tried to do is to really understand the legacy around dental commissioning, but also about how we can improve things in the future for our patients of Staffordshire. So the report is an update on the current dental position in Staffordshire, outlining the performance, the challenges, any local initiatives, etc., to improve our position. I think it's safe to say that dental does still remain challenging in terms of recovery. There are long-standing factors around dental, as well as the post-pandemic impact. And also, whilst we have the responsibility around operational performance, there are still challenges from a national perspective in terms of those national negotiations around the contract. So that's all to take into account. So in terms of that, and just to explain a little bit more about that, the ICBs, whilst there were changes made in 2022 to the contract, one of the major changes that didn't happen was the ability to rebase contracts. So what we're unable to do is to take activity out of contracts that aren't performing and to put that elsewhere of most need. And this is a similar challenges to what other ICBs are facing as well. So quickly then, from a Staffordshire perspective, we have 129 dental contracts currently. The paper outlines the long-term trends for the ICB in terms of dental activity. So in November, you will see that the activity delivery sat at 82%, and that's contracted activity versus actual delivered activity. We are, however, tracking performance that is slightly higher than this time last year, and so we have submitted this paper, but we do now have the December data, and we are just over 93% for delivery in December, so we have seen a bit of an increase there. Cumulative delivery is at 50.4%, so you'll see within the paper 62% is the level that we would be regarded on track to deliver 100% of the activity that we commission. And just to be aware that there is obviously lots of local variation across our dental practices in terms of over-delivery and under-delivery. You will see it's also highlighted within the paper that there is significant issue with under-delivery across some of our bigger corporate contracts as well. The main issues to recovery, and you will have heard this from a previous paper delivered back in June, workforce challenges, so there is recruitment and retention challenges. Dentists are choosing to work privately and outside of the NHS. Again, the national contract, which I've just mentioned, and the associated issues around the national contract, and then that's ultimately leading to some contractors who are handing back their contracts as well. And as I've said, whilst we're currently not on track in terms of the dental activity recovery, it is worth bearing in mind that we do have that variation across our over 100 dental contracts. Some are over-delivering, some are under-delivering. Access is reported in terms of numbers of unique patients that you'll see within the paper, which are patients that have been seen within the previous 24 months. We are very much in common with other Midlands ICBs, so we're seeing smaller increases of those unique patients now, and that's due to the ongoing shortfall of capacity in delivering that contractual activity. So the gap between now and pre-pandemic numbers, unique patient numbers, are just over 76,000. There is a piece within the paper around orthodontic treatment. It explains what orthodontic treatment is, etc., so I won't go through that. We do have 22 orthodontic contracts in Staffordshire. Some are specialist, some sit alongside the general dental services. The paper describes how that activity works, and just to note, there was some additional investment through NHS England to provide some additional cases of orthodontic treatment, and that was to recognise the long waiting lists that we know patients are experiencing at the moment. So there were an additional 1,070 cases that were commissioned. Activity at the moment, if we took those additional cases out of the equation, we would be delivering at 91.6%, but with those additional cases, we are 56.8%. So work is ongoing with those that are commissioned to deliver these additional cases, to work with them to assure that they are achieving that contracted target, including that additional investment in March 2024. As I've said earlier, the contractual changes that were reported in 2022 obviously had that exception of being able to unilaterally rebase contracts. Nationally, we are expecting a dental recovery plan. That still hasn't emerged yet, but we are waiting for that. We're hoping that that does come soon. There is no timescale to that in terms of when that is due to be released. Within the paper, you'll see the local initiative section around the Children's Community Dental Support Services, which I know you've seen previously in a paper last time. That's in terms of care closer to home and reducing that pressure across the system in terms of 111 and A&E. And obviously, there's the really vital work around redistributing activity where we can. So where we do get activity handed back as part of the contract, that does enable us to redistribute that activity to places of most need. And that obviously then improves our access performance position. So as I've said, as an ICB, we're working really closely with our Office of the West Midlands colleagues and the 5 other West Midlands ICBs. We are currently in a draft dental strategy for the region. It does contain very much local information within there, but it is across the region. The strategy, I would say, focuses on 4 key areas. So Workforce, as you might expect, is a key area within that strategy around recruitment and retention and skill mix within dental practices. Improving equitable access and reducing health inequalities. Obviously, the piece around an increased focus on prevention and oral health. And then how we strengthen relationships within communities, and that's with our patients and public as well as within the system. What that strategy will do is almost develop our improvement plan. So there's very much within the strategy a draft programme of work, which will then inform what we do moving forwards. Within this, there will be things that we can control, there will be things that we can influence, and there will equally be things that we can't control, i.e. the dental contract changes that we are waiting for. However, what we will do is respond as part of once we know what those are. So we are on track to deliver an improvement plan within the second half of the year. And then to further enhance this, as my final comment, we are currently in the middle of a health equity audit for Staffordshire in terms of dental. So that's looking at the health determinants, looking at access to health services and the related outcomes for our population. This health equity audit will almost inform our dental strategy, as well as helping and guiding that process around redistributing activity where we can to the places of most need. So taking into account, for example, urban and rural parts of Staffordshire, as well as health inequalities as well. It will also enable us to determine priority areas within Staffordshire as well. So that will then feed all together, hopefully, with a dental strategy, a health equity audit that we can then develop that draft programme and hopefully then a finalised programme of work as we move into 24-25. And finally, we are working really closely with colleagues across the local dental committees and the local dental network on a key set of priorities that we can all agree together as we go moving forward. So I'll pause there. Thank you very much.
Thank you, that's helpful. Charlotte, I'm just mindful that you started the meeting, you joined the meeting after we'd started, and you probably want a declaration of interest, probably.
Yeah, I'm Vice President of the British Fluoridation Society.
Thank you, noted. That's helpful, thank you. Sorry, did you now have a question that you wanted to come in on? Sorry, I wasn't trying to, I was just to make sure that we were appropriate.
To make that statement. Somewhere within the document, you say that the transfer of funding, it's on page 101 in terms of our pack, the transfer of funding from dentists who are not meeting their targets could not proceed due to other pressures on ICB finances. Does that therefore mean that dentistry has a very low priority within the ICB? That's the first question. How many dentists do you have who are willing to take on the additional NHS capacity? Where are they? And are they widely spread? Are they in particular locations? And does that indicate that where are the NHS dental deserts where we have no practices taking on NHS patients? Now, as I understand it, complaints to the NHS Ombudsman in terms of dentistry has risen by 66% in 5 years. So what are you doing about ensuring that the service that dentists, both NHS and private, are giving to patients? Because one of the issues is that if you're being forced into, if you can afford to, and are being forced into a private contract, very often the pricing mechanisms are incredibly opaque, and therefore people end up with bills of hundreds, even thousands of pounds, when they're not aware of that once they enter the dentist's chair. So if you could answer those questions, please.
Tracy, we're with you.
If I take the first question, then I'll pass over to Paul in terms of funding. So what we don't know at the moment is we haven't got access to an overall picture in terms of NHS patients and who's taking on NHS patients. So whilst we know it's really challenging, we don't have the overall picture, and that's because it's up to dental practices to input their information onto the NHS website. However, when you do go onto the NHS website, and I think I put in Stafford on Friday just as an example, and you do a radius around that, there are very, very few that are accepting NHS patients. So we absolutely understand the challenges around patients being able to access NHS treatment and the costs that are associated to that. I think that the bit that I suppose within the paper to highlight is we can only do what we can do in terms of that redistributed activity at the moment, in terms of putting that in the areas of most need. And we're hoping, as I've said, the health equity audit will help and guide us in terms of where those real gaps are. Does that answer your question in terms of that?
It worries me that you haven't got that information, because if you were to put leak, for instance, where I live, into that search engine, then you would find, again, nil. And what worries me is that, anecdotally, what I'm hearing is people have just given up on NHS dentistry. And given we're in a cost of living crisis, possibly, wrongly, but possibly, people will not prioritise their dental health over food, because obviously that comes first. So what I'd like to know is what you're doing to monitor the impact of this lack of NHS dentistry on dental health. I mean, one of the other questions I want to ask is what is the waiting list?
Shall we focus in on one question at a time, Charlotte? And I'm keen to hear from the people in front of us, please.
Okay.
Yeah, so just in terms of just going back to your question around how do we not know that, we have 129 contracts and that position can change quite quickly. So we'd have to obviously go onto the website every single day to enable us to monitor 129 contracts. However, what we do know is we do know about pattern around complaints, PALS queries, etc., MP requests that come in around particular pockets of areas where we know there are issues. And that's where, when we do get redistributed activity, it is really important to note where we do have those gaps. So that's what we use to drive some of that at the moment. And as I've said, the health equity audit will also guide us in that direction as well.
So when will you publish that?
So the health equity audit is due at the end of March. And that should coincide with our dental strategy as well, which I can present back.
Can we just pause there just a minute, please, Charlotte? I'll come back to you in 2 seconds. Can I just ask 2 or 3 questions which relate to that? Is it dental only within this health equity audit? Dental
yes, that's correct, yes.
Okay. And if what you said to Charlotte was that the position changes in terms of availability of NHS capacity, then how will the audit, if the position changes at any moment in time, how will the audit give you an accurate picture that will answer Charlotte's question about deserts?
So the health equity audit will help and guide us in terms of where we do have significant gaps. I think the question that Charlotte was asking was around how do we not know on a regular basis who is and isn't taking on NHS dental patients. So I think that's 2 slightly different questions.
Okay, does anyone else, Charlotte, do you want to come back in on this specific point, or anyone else want to come in on this specific
Well, yeah, I mean, what I wanted to find out really is what advice you give people, because, you know, children might be able to get NHS treatment, but what advice what advice would you give to someone who's listening to this debate and can't find an NHS dentist? What do they do?
And it is a matter, so when we're responding to complaints and PALS queries, for example, what we have to do is to guide them in the direction of the NHS website, or we provide particular practices where we know are taking on NHS patients. It is really challenging. I'm not going to sit here and say everything's okay, because it isn't. We do know it's significantly challenging, but we can guide them in the direction of where we know dental practices are taking on NHS patients.
Just, if we can pause again, Charlotte, where there's a few others who want to come in on this specific issue. But just let me ask one other, sorry, Paul, it looks like you want to come in. Just let me ask one other question. Are you going to take this health equity audit, which is coming at the end of March, I noted, are you going to overlay the population health management data of deprivation and other indices on top of that to actually give you a multi-layered? I'm getting lots of nods. So let me bring in a few other people who want to come in on this specific topic. Janice.
Yeah, thank you, Chair.
Sorry, just before you do, Anne, I'm assuming it wasn't on this issue, was it? Okay, thank you. Janice.
Yeah, thank you, Chair. This was the first question that I had on my list, was geographic exceptions, because that was one of the things that we didn't get any sort of visibility of in the report. And I am very much cognizant of the recruitment and retention issues that you've mentioned, and also the contracts, because I've had conversations with dentists separately myself, and they explain quite categorically the vagaries between one practice that might be located one side of the road and the different payment mechanisms that the one on the opposite side of the road gets. So I'm with you on that one. But a number of us also sit on different panels, and one of the ones that I sit on is corporate parenting. And we know that some of those assessments that need to be made for those young people in particular are time limited. They need to be done. And it became absolutely apparent as to how people having to drive for a good distance, in some cases over an hour, from one side of the county to the other to get to those services. And for me, this sort of, although that's quite a niche part of what we're looking at here, just exemplifies those geographic exceptions, and I too, at this point, notwithstanding the different contracts that are in place, to be able to plot where those gaps are, I think it should be absolutely glaringly obvious. And knowing that some of those contracts will be in place for some time, and notwithstanding the fact they do change, that we have a lot more attention that we can put onto those. For me, it is how we now manage and best serve all of the residents, but how we can try and bring attention to those in the vain hope that we might actually attract providers who might want to go there, given the right incentives. Thank you, Chair.
Tracy.
I think Paul wanted to come in.
Okay, sorry, Paul.
Sorry, Chair, I'm just going to come in. While I've got a little bit of voice left, I'm just going to come in on one or two of the issues that have been raised. I think it's important that we recognise that dental is governed very differently to medical. So the national dental contract constrains us quite considerably as to what we can do locally in a very different way to the way that we work with GPs and primary care. The way that patients are registered, for instance, is very, very different. GPs will have an open list. You're able to register with GP. You become their patient. It's very different with a dentist. They don't have a registered list in the same way that GPs do. It depends at a moment in time, to be honest, as to whether they have the capacity or willingness to take somebody on. I think in terms of the health equity audit, Chair, that you asked, the health equity audit will only ever give a baseline at a point in time. We're doing that health equity audit alongside all the other ICBs of the West Midlands, so we will have a benchmark across the West Midlands for the first time. And rather like the Joint Strategic Needs Assessment or others, it allows us then to build on that. It will show us where we've got, it might be the deserts, it might be where we've got particular issues with children's care or whatever, and it will allow us to build, and then the population health management comes in that we can start to drill down into that and say, well, what are the other factors, what are the comorbidities, what exactly are we looking in that? So I think there's lots that we need to learn. I think we also just need to remember that dental has always been a specialist commissioning done at an HSE level. We're in the middle now, really, of a delegation and a shared commissioning down to local areas. So this is really the first proper opportunity we've had to really, really start to influence what happens. In order to do it as well as we would like to, we need some changes to the national contract. We are promised that those are being looked at and being moved forward. We're in an election year. Whether we will see that during an election year, I don't know. But we need some greater freedoms in terms of how we can move the money around and be able to do it. So I'm sorry, Chair, I've picked up a couple of points in there. I don't know whether that's helpful.
Yes, thank you. And obviously, the other bit is the ICP took over responsibility in April last year for dentistry, which I do understand. Janice, did we answer...
I think that it's work in progress.
Okay.
Is the honest conclusion to that.
Let me bring in Bernard, and then I'll come back.
Thank you, Chair. Good morning. I wonder if I could just shift the conversation to the impact on communities, not of accessing a dentist, but what is your communication strategy in terms of working with retail outlets to discourage them, for example, having things that would affect children's teeth on the checkout? Chocolates, sweets, parents succumb to the pressure of 2 hours shopping. Yes, you can have a box of chocolates, whatever. Have you got a strategy to address that? And are you getting good responses from retail outlets in that regard?
In terms of professional background, Councillor, I'm a public health consultant, and this has been very much led by public health over a number of years now. You'll be aware of things like the sugar tax and things like that that have been brought forward. It's absolutely on the public health agenda. It's led primarily by the directors of public health, so Richard Harling in the county and Stephen Gunter in the city. From our local point of view, it's absolutely up the top of the agenda. The associations of directors of public health and very much driven forward. In that, we would play a supporting role in that because it's very much that public health agenda driving that forward. But we're aware that we have pockets of quite significant childhood issues in terms of the numbers of operations that need to be done, the number of children and so on, and we're able to pick that up. And again, that will come out of the health equity audit, and that will give us, if you like, increased ammunition to be able to support our public health colleagues in terms of pushing those agendas, in terms of how we do some of the, to be honest, very simple things, as you say, like moving sweets away from the checkout counters, reducing numbers of takeaways, being clear about the amount of sugar that there is in particular foodstuffs, etc. So there is a big movement within public health to do that, and we'll provide that supporting role from ourselves.
Bernard, we're with you.
Joining those dots there, of course, it's good to hear. Thank you for sharing that with me. But my mind then slips to type 2 diabetes, aggravated by large intakes of sugar, and then that's somebody else's problem. I hope it isn't, but we need to get joined up on that because it's an incredible demand on the NHS looking after type 2 diabetics at the moment. Thank you.
Just to come back on that, Chair, absolutely. We know that starts in early childhood, don't we? We've seen figures just coming out showing about how childhood obesity has increased during COVID. We know that. And those issues start to compound from there, the oral health issues, the obesity issues, etc. And then we see that further down in terms of type 2 diabetes. And as you say, the impact on the NHS is huge. One of the biggest prevention agendas that we can move forward on and will move forward on is prevention of cardiovascular disease, and diabetes as part of that.
Thank you. I've got a whole ton of speakers on various things on this. So can I just go back to where we were a minute ago and ask anyone who's indicated, do they want to specifically pick up this point? I think Baz does. But before we do move on, can I just make a comment in terms of Bernard's questions? In terms of the public health role, don't forget that you've got district and borough reps on this committee. You've clearly got family hubs, which is a county council element as well. And there is the role of councillors as well well. So, you know, do by all means come back to us and ask us to put our weight in the same direction, because, you know, what you're talking about is really important. Baz, and then I'll try and bring people in as we go. If you can just indicate to me that you were on the same subject, but let me bring in Baz.
Yeah, hi, thank you for that. Yeah, it's just bringing it back to the earlier point about as a health watch, when we get contacted via residents and patients asking about, you know, NHS appointments anywhere, and how it comes across, and this is just to give a bit of feedback, I suppose, more than anything else, is that as an agency, what we're trying to do then is ring around in the hope to find somebody for that person, which is great for them in a way, because at least they get that support, because they do get very frustrated. The only issue is sometimes it is, as mentioned earlier on, an hour away, and due to cost of living, having to take a day off work, they don't always then go. And it's just to give that little bit of feedback about that impact that it is having on residents. Okay.
Thank you. That's useful. Do you want to come back on anything Baz has said? No? Okay, thank you. I'll take them in the order I've seen, because I don't think anyone's indicating they want to pick up the specific point. Angela.
Thank you very much, Chairman. Yeah, my question relates to, knowing that we've got many vacancies for dentists and that, what are we trying to do to recruit dentists? Are we looking outside the UK, like we do for GPs, or is it, you know, just do we wait until they come along? And all right, Bernard's picked up the other question about children, because I want to ensure that our children have got an access to a dentist wherever it might be, because, you know, if we don't look after them in childhood, then we've got a major problem as they get older. Thank you.
So in terms of the dental strategy, as I've said, there is a section within there around workforce, and specifically what we're looking at is schemes that can support retention of our dentists, and that's also to make them feel valued, like they're part of something. So there's a real focus within that. There's something about improving the career profile of a dentist. There's something around skill mix, and you'll hear furthermore in the GP access piece around how skill mix is having an impact in terms of general practice. Actually, there's lots of opportunity within dental as well to do some of that skill mixing. We want to understand our local workforce and how we can plan with educational institutes and also our local training hubs around how we build education within that, and also different models of delivering care and who needs to do that as part of that skill mix. So there isn't a tree around growing dentists. We don't have that magical tree, but actually there's lots of things that we can think about as part of our recruitment and retention plans around not only dentists, but also broadening roles within dental practices as well, and using that skill mix. To go back to your second point, which I think was about children, is that correct? So we do have the service around vulnerable children and adults, and around emergency and urgent care, so the CDS, which is if children are struggling to access dental locally, there is that service there, and I think that was talked about during June's committee, so I won't go into detail about what that is, but there is a service there that can support children around that as well.
Anne?
Thank you, Chairman. You talked about training hubs. Do we have any training hubs in the area? And, you know, yeah.
We do. We do.
Yeah,
yeah,
right.
We have a Staffordshire training hub. So that is a local hub that covers both Staffordshire and Stoke-on-Trent. Yes,
Where is
we
that
do.
based?
And we're working really closely. So they're based in Stafford. So it's through actually one of our GP federations. It's a company called GP First, and they run the Staffordshire training hub on behalf of Staffordshire and Stoke-on-Trent, working very closely with Health Education England.
Thank you. Just two things on that. You just reminded me that we, I don't think I've seen a response to the letter we sent to Keele University about whether they were able to set up a medical dentistry school. We will follow that back up and send a further letter, and maybe copy yourselves to it. That might be a useful departure. And I was hoping you were going to reference the work that Mish Irvin is doing in terms of workforce and integrating into that, because there is a lot of activities that she is doing, which is bringing some extra people into the workforce. But I'll move on to Keith, if I can, please.
Thank you, Chair. And mine does relate back to numbers, which as I tried to indicate a bit earlier, but never mind. In relation to how people are currently getting their NHS treatment, if in fact they can get that, My concern really is about the fact that families are split. My own family is split already. And it's where we found the stuff. I think we've already had from Baz about the idea of travelling. It's not just for those families that are desperate for that. It's virtually every family, I think, at the moment may well be split. My concern is that you go and try and do this gap analysis, and of course, you don't really, the data you're getting back is geographical, but in fact, people are going miles, probably outside the county as well, cross borders and everything else. It's a bit of a mess out there. So my concern is that you don't get that information in, and you've got 129, is it, contractors at the moment with that information. How are you going to compare all that and get it all together to something that actually makes sense? That's my concern. And then you've got students and everything else on top of that generate some coming in, some going out. And that's my first concern. How are you going to get over this issue about the fact that it's broken and we want to fix it, and we want to try and make it so that we can understand where the gaps are statistically? That I can't see how that's going to work at the moment from what you've told me so far. So I might be wrong, but I'll let you come back on that. I've got one other question after that. Thank you.
I think the only thing to say is, yes, it is a challenge, and we're up for the challenge, and we want to see what this health equity audit and overlaying that with the strategy. It's certainly you know, I'm not going to pretend that it is going to be an easy process, but yeah, we're up for the challenge. I can't say any more than that at the moment because we are going through that process at the moment.
Sorry, I think the inference obviously is that we need to bring you back in due course. Keith, I'm going to move on because I'll put you back on the list. No, I'll put you back on the list because there's still Charlotte who's also wanting to ask some questions. I've got a lot of speakers. I would ask our speakers to be brief, though, in their questions. Chris, let's start with you.
Yes, thank you, Chair. Obviously, this is a picture that gives us cause for concern, and I think the sooner we have a dental recovery plan and clarity about the resources to support it, the better off I think we'll all be. We need to remove that uncertainty. A couple of quick points, if I may, Chair. We talk about informing people about the position, and the feedback I get regularly is that NHS 111 is not well informed as to the current position. So I wonder if that needs a bit of work, that relationship with NHS 111 needs a bit of work, because that's where people are advised to go first. And the second point is a very specific one about the provision of dental care in settings such as residential and nursing care homes, in acute wards for people with severe mental illness and all of those things, those special dental services. I've heard a number of concerns, and I think if you look at care homes, the relationship between oral health and infections such as pneumonia has now been established. So clearly it needs to be more of a focus than perhaps we thought it was previously. So I'm just wondering what the position is regarding those special dental services and what the position looks like being in the future. Thank you, Chair.
Thank you.
I'll take the first point in terms of NHS 111, and I will take that back as part of feedback. It's not something that I've specifically heard. Our colleagues in Office of the West Midlands may have heard that, but I'll certainly take that point back. Paul, do you want to pick up the bit around care? I mean, there is some significant work going on with care homes at the moment around improving oral health. I don't know if you wanted to pick up anything in terms of specialist support.
I think just to say... it's difficult to look at you and speak to the mic as well, sorry.
And it'll be useful to address your comments through the chair as well. No disrespect.
Yes, sorry, Chair. In terms of 111, again, I've not heard of specific issues. On the other hand, 111 is largely reliant on the NHS website, and so it's how good the NHS website is and how they go into that, because that's the source of our information at the moment. We don't have any greater information really than that. As I've said before, it's not like GP practices where we've got an overview of exactly what's going on and where things are and so on. On the one with vulnerable adults, again, there is work that is done with the public health teams. So there is work that public health teams do in reaching out to both children and to the vulnerable adults. And then there's also the team that we talked about before, which is the Children and Vulnerable Adults team that goes out. And that team is available to come out. It will vary across the nursing homes and the care homes as to the level of access they've got. but absolutely take the point that when we do our dental recovery plan, the oral health care for elderly residents and those with severe mental illness has got to be a very high priority. It can lead, particularly with residents who've got dementia, and may be unable to tell you that they've got a problem. It can cause them to stop eating, etc. And so it's really important that we have that good oral health care for those vulnerable residents. Chris, anything further?
Yeah, I mean, that's quite reassuring. It would be good to know where the provision is weakest or where it is less developed, so that we can actually work with people. I think that would be extremely helpful.
And I think that's what we're being promised, and we just need to decide when's the right time to bring it in. But I think inherent in your question, I think you have some examples of where NHS 111 isn't working, Chris. And if you have those, I'm sure the ICB and the people in front of us would be really keen to look at those as live examples, obviously with the right data protection stuff, and happy to provide a conduit for that, for people to investigate. Jill Hood.
Thank you, Chairman. You've spoken about the public health teams. I have a lot to do with first schools in my division. And when I'm talking to parents, I'm made to realise that many of the children, even in year 4, have never visited a dentist because there isn't provision for that child to actually go along there. Charlotte's touched on the fact of, there's no other word for it, child poverty. If you're going to offer a family a placement in a dentist that's 20 miles away, there's no way that that family can afford to even get there. And, you know, I'm a prolific user of social media. I really enjoy it. When I go onto any of my social media, I am bombarded with local dentists who want to give me £20 off an implant day out. I can go along to their surgery and I can have a look at what they're doing. And it's such a failing that children think that, and possibly their parents through ignorance, that we can allow children to grow up. And when they get to 18, there'll be a magic wand where they can pop off to Turkey and have the full turkey set for a minimal charge. You know, people borrow money to do it. It's so very sad to see these children with decayed teeth, with brown teeth. And to me, it's more important that at a very young age, we employ preventative dental techniques in schools. And I remember asking for my grandson at the local nursery, he doesn't enjoy brushing his teeth. Is there any chance you could bring it into your curriculum? And they were horrified and said, no, that's not our responsibility. To me, it's as important as potty training at that early age. But costs really, really are worrying. And when you've got parents with 2 or 3 children, you know, it must be terrifying to know that you're going to have to pay for those children to have dental treatment. So with the public health team, is there any way that we could find some funding? There must be some funding in place. Surely this government recognises the importance to make a real effort to get those public health teams around all of the schools to go on television. And I know this may be a ridiculous thing to say, but you put a Disney channel on and have a look at those children acting, those young children acting in American films with their perfect teeth or their braces, and then have a look at our British children. We certainly are failing them big time, and we need an absolute kick up the backside to try and put something into place to help these people who are struggling with dental treatment.
Yeah, we can't underestimate the importance of prevention. So just to be aware that there is some oral health promotional work that's taking place at the moment around supervised brushing, and that's in early years settings. So there is areas of work going on, and I'm hoping that comes out when we do our strategy and how we develop some of that work. It actually did hit the national hit a national TV show last week around the importance of teaching some of this within school settings, etc. So I'll certainly take your comments on board. It is forming part of the dental strategy around oral health and health promotion, etc. So I'll certainly take those comments on board. Thank you.
Thank you, Tracy. Jill, are we happy? Thank you. David?
Thank you, Chair. It's just a question and also just a clarification of a term that we used earlier. So I'm interested for colleagues on page 27. So I'm just interested in what the ICB is doing to mitigate the under-delivery of corporate dental contracts, which is at the bottom. And is there any levers that the ICB can pull around that, or is that a difficult thing to do?
We're in the same position in terms of what I've described earlier. We can only get activity out where, at the moment, where that is handed back. We can't unilaterally rebase any of our contracts, and that includes corporate contracts.
Okay. And my second thing is around what do you mean when you use the word skill mix in dental care?
So that's using other roles around, you know, supporting, for example, hygiene, so using dental hygienists, dental support workers, etc. So there's lots of different roles within dental that could potentially be utilised, and that's where we need to look at how pathways of care work and where that skill mix can be maximised in terms of dental practices.
Okay, thank you. Thank you, Chair.
Thank you, Kath.
Thank you, Chairman. Just a couple of things you may be able to answer, I don't know. You mentioned a couple of times West Midlands, which I'm assuming we come under that scenario. And it's a mapping system. How poorly off are we in Staffordshire? I'm talking of Staffordshire now, when it comes to dentists wanting to accept NHS patients, as opposed to we've got other surrounding authorities, north and south, east, west, when it comes to that. So where do we sit in that scenario? Because at the end of the day, it's all about affordability. Dentists are there, it's a business. So they're obviously going to pursue their businesses, obviously. So they may not want to take, which I'm assuming is what's happening now, they don't want to take on NHS patients. So how are we going to bridge that gap, for the want of a better word? You've mentioned a few things this morning about March, etc. But I just wondered, and also where demographically are all these that we've already got now, NHS dentists that want to take NHS patients, where are they around Staffordshire? I'm assuming I can look online, but just off the top of my head, for me, where are they? Where are we short of them for the want? Staffordshire Moorlands has been mentioned, but where are we short in Staffordshire, in the map of Staffordshire, because it's a big area. So if you can answer any of those questions, please, I'd be grateful. Thank you.
So in terms of the West Midlands picture, that dental strategy is going to tell us that. So that will have all of the information across the 6 ICBs, of which we form one of them. So we will be able to compare ourselves, as Paul said earlier, around how we do. I mean, it is very challenging in Staffordshire and Stoke-on-Trent. However, I am hearing that it is challenging in other areas as well. So that will be able to guide us in terms of what the data tells us. Just into what was your other second point, sorry, in terms of pockets of areas, was it?
Do with the affordability. Obviously, in more affluent areas, dentists are going to want them to pay for their treatment. Sorry, they're a business at the end of the day. So I'm just wondering where we sit in that scenario as Staffordshire, because we have got some affluent parts, but we've also got some deprived parts as well. Thank you.
Yeah, so as I've said, the health equity audit will open some of the world out to us to be able to see some of that. What I can tell you now is in terms of where we get regular complaints, etc. We know that there's pockets of Burton that is particularly challenging, Utoxeter that's particularly challenging. Those are the areas that are coming to me from the top of my head at the moment. But as I've said, the health equity audit will be able to open our eyes a bit more in terms of that, because those are the patients that are complaining. We don't know what we don't know in terms of the numbers of patients that aren't.
Thank you. And maybe, and Charlotte referenced complaints earlier as well, but albeit Charlotte was talking, I think, nationally, maybe we could see on the next time that you come just where the complaints are centred in Staffordshire. Obviously, we're not interested in the national picture, but I think I think they're good points just to help inform that discussion. I'm just going to carry on and go around the people who haven't spoken for the first time yet, and then I'll come back to the others. Leona.
Thanks, Chair. We mentioned about preventative methods for children, and also less sugar as well. But I'm also interested in hearing about other ages, for example, like reduced alcohol, caffeine, processed food, which is really bad for overall health. Do we have those prevention methods in place now? And also, I want to also ask about, we promote how to clean effectively, our teeth, the mouth in general, but that's, apart from brushing, is there a push for flossing, but even water floss that's coming in now, and that's really important as well. Thank you. And I've got another question after.
I think Paul has picked up quite a bit around the prevention. I don't know if there was anything else, Paul, that you wanted to add in terms of that.
I think just to say, Chair, again, that sort of with prevention, it's very much a shared agenda across local authority, both at upper tier and lower tier level, but also with the NHS. And it's something that we very much bring together through the Integrated Care Partnership strategy that we've got, and very much something that we need to work with, because it's like anything else. The more that we can prevent, the more that we can stop early, then the less the issue is in terms of provision later on. So I think it's just a shared agenda. It's probably one that we don't fully understand at the moment, exactly where everything is. And I think following the health equity audit, rather like when you get a revised joint strategic needs assessment, the next stage after that will be to say, and so what? What do we need to do? What do we need to do around prevention? What do we need to do together? What do we need to do about delivery, etc.? So that will be the next stage after we get the health equity audit. I know it sounds as if we're pinning a lot on this equity audit, but I think it will put us in a position that we've not been for quite a considerable time. We used to do, years and years ago, there used to be checks done at school on children, a sort of audit that was done at schools. That's dropped away, and I think is only done in a couple of areas now. Part of that is because of the pressure on the public health budgets in local authorities. Public health, the real purchasing power, I think, of public health grants has gone down by about 25% in the last 5-6 years, and that's putting a lot of pressure on what local authorities can do with that budget. And I think one of the things that went was the, I think it was done at about, as children left school, so it was done at about age 11. We had that data. We've lost a lot of that data now, but the health equity audit will help us with some of this information that we need.
Understand. Leona, are you on the same question? I don't want to move you to another question because there are a whole set of speakers who want to come back on other questions they have.
Just one more about recruitment really quickly. I just want to, do we have like a dentist point of view? Because we know that, patients, whether they're satisfaction or not, but it's really interesting in terms of recruitment and retention. Do we have dentists like a survey, like point of view, why, do they not feel valued? Why are they not sticking with NHS? Or is it because of, if we're going back to basics, is it because of education? Is dentistry too difficult now compared to in the past? Thank you.
I think one of the biggest things that we hear is the difficulties around the dental contract and the issues that presents. So what we do is, and I think it was the last point I made as part of the paper, we are working really closely with the local dental committees and with the local dental network, who are almost the voice for their profession. So there isn't a particular survey that I'm aware of that goes out to dentists. However, that might be something that we want to consider, but we certainly hear the voice of, and we do have dentists that approach us directly and talk to us about some of those challenges.
Okay, thank you. And can I just pick up your answer, Paul, to the previous question, which was, about integrating across the public health agenda. What role is the Health and Wellbeing Board playing on this key element, please?
Again, Chair, absolutely. In terms of the public health agenda, So public health agenda for the two upper tier and for the lower tier local authorities is very much looking at that population and their own population. So Stoke-on-Trent will look at theirs, Staffordshire will look at theirs, etc. To an extent in isolation. What we do through the Integrated Care Partnership is to bring that together, and the whole thrust of the Integrated Care Partnership strategy is what could we jointly do that would make the sum of the parts, if you like, greater than the individual parts. So what could we add to what's already happening through the Health and Wellbeing Board? So, for instance, Tracy talked about the supervised brushing of teeth. That would be led through the public health teams, through the Health and Wellbeing Board. The question for us, I think, working as a collective across health and social care and public health is what else could we do to join all the dots together on that and to make that more comprehensive, more systematic, working together. So I think it's building that up from the health and wellbeing boards.
Yeah, and the level of priority that they're putting on it. And maybe that's something we'll take back as a committee to them. Richard Cox, and then we're on to people who are on to second rounds.
Thank you, Chairman. In your preamble, you made reference to the rural Staffordshire, but obviously the report doesn't pick out any particular instances and so forth. Obviously, rural Staffordshire, you know, it's a complex network of roads and so forth, and it is about that, you know, connectivity. When a practice may retire, for example, which happens to be one in my own division, but then there's no intake of somebody taking up that particular surgery. And it's a concern that what are you then doing to try and encourage it, that that particular surgery is viable, it is there, it is needed, and that obviously could be right through Staffordshire, not just in my division, but it's important that we've got that as a focus. And I was wondering exactly how you are focusing that issue.
Yeah, I don't disagree. We work really, really closely with providers in terms of sustainable. What you're talking here is about sustainable dental practice. So clearly they have a level of commissioned contractual activity that they are supposed to be delivering on. And we work with them to try and make sure that we try and get to 100% as much as possible, but sometimes that just isn't possible due to capacity and all the issues that we've talked about today. So, and that's why I've talked about how we then look at those health inequalities, the urban versus rural, what does that mean for us, and this will all form part of what I've talked about earlier and described earlier.
Thank you. I would ask the people asking additional questions, we're sort of running through on time, so I'd ask them to be brief. Charlotte, then Keith, and then Janice.
Yeah, I just wanted to ask about orthodontics. What is the current wait time for an under 18-year-old to get orthodontic treatment? And what happens if that child hits their 18th birthday while they're waiting? Are they then taken off the list? What happens? And what are you doing to try and promote orthodontic treatment? Because that can have a huge impact on a child's confidence and on their outcomes for education.
So in terms of orthodontic waiting lists, we actually don't hold that information. This is information that's held at individual dental practice level. So I'm not able to give you numbers in terms of waiting lists at the moment. We do know it's very, very challenging, though, as I've described, and you will see within the paper. In terms of the 18 years, that is a question I'm going to have to take back unless my colleagues... So that is a question that we'll have to take back. So can I just clarify, it's once the child hits 18 years old, what happens? I'll take that question.
If they're on the waiting list. I mean, I have to say that I'm somewhat shocked that you took responsibility for dental health and you knew you were going to do that nearly a year ago. And what we're getting today is a load of we don't know, we have no idea, we can't get that information, we will wait until March, until we have our audit. You know, people out there are desperate for dental treatment. And I think until you realise how much you need dental treatment in an emergency, you don't realise how important dentistry is. And, it seems to me that the ICB are still not making a priority. It is a priority and has a huge impact, not on just physical health, but also on mental health.
Is there a... Thank you. I was going to say, is there a question? I'm not sure I heard a question in any of that, Charlotte, so can I move on to... Well, I suppose there is a question. What is the level of priority from the ICB? I think that's a fair question.
Why is it such a low priority when it is so important?
No, OK, I think we've understood the question. Can we
I think just to reassure Chair that it's not a low priority at all. It's absolutely a top priority for us. It is something that we have taken on more recently. It is something where we are very constrained by the national contract in terms of what we can do. We're also very constrained by the fact that dentists don't have a registered list. There is no way that we can go on like we can for a GP practice. We can go on and we can see a particular GP practice has 2,222 patients, and we could see a list of every single one of them, and we know what happens with them, they know where they go, we can track them through. We can't do that with dentistry. There is no way that we've got that level of detail. And until or unless we get a real change in the national contract, going back to, I can't remember when the contract changed, back 2003 or 4, I think, when it changed. Unless we can go back and we can retrace to there, we won't have that information, and no ICB in the country will have that information. So what we need to do is to build that information as best we can over the next year or two in terms of what's happening locally. But it is absolutely a top priority for the ICB, I assure you of that.
Thank you, Paul. That's helpful. Keith, briefly, please.
Yeah, very briefly, it's just exactly the same thing, really, orthodontics. I would just like to know, are you going to bring forward an improvement plan for the orthodontic section when you come back to this committee after you've done all your assessments in March?
I think that was crystal clear. Sorry, I'm going to move on to the next speaker, please. I think that's crystal. We're going to run out of time on this debate. Thank you. Janice.
It was the same question, because it was the one I asked a few months ago as well.
Okay,
Thank
so
you.
if it's the same question, then I think we can move the debate to a close. Sorry, I just recognise that we've got more other things that we do need to cover, please. I very much clearly hear that it's work in progress. I very much clearly hear, it's not often we have everyone in the chamber wanting to speak on and ask questions on the same issue. I cannot remember the last time that happened. So it's clearly an emotive issue from both sides. And there is no criticism of the people in front of us this morning in terms of trying to solve the problem. I also hear that you have a dental recovery plan that you want to bring to us, that you want to overlay that with the health equity audit, and within that there will be sub-strategies in terms of early years, in terms of residential care, and those people most susceptible and most vulnerable on this, and that within that you'll also look at the complaints data. We will liaise with you in terms of when is the right time to bring that back to committee, because I would hope that would be during the summer, because I would guess that there's half a dozen strands of activity that you want to pull together alongside the ICB, and we will want, I'm sure, to be able to scrutinise that in just the same sort of detail, and we may actually need to look at a single item agenda, but I'll take advice from committee on that. Is that a fair summary of where I think we got to today? We're very much work in progress, is that? Yes. Are we happy with the actions that we've talked about, with the exception that I will also rewrite to Keele University again? Yes. Okay, thank you. Let me move on to the next item on the agenda, which is the access to general practice. We've seen access to general practice a number of times through committee, so I think we're quite well versed on this. Maybe we can give you 5 minutes just to introduce the paper, 5, so that we can try and catch back some time, please, because I'm mindful that you have a hard and fast of midday.
Of course, thank you, Chair. My name's Sarah Jeffrey. I'm Portfolio Director for Primary Care for the ICB. So thank you very much for allowing us to talk about access to general practice here again, as we've done a number of times. NHS England back in June released a national plan for releasing access to recovering access, to general practice. And the aims really are about tackling the 8 a.m. rush. That's all we hear, isn't it? From our communities, from our patients. Can't get through on the phone. Then when you do get through, you can't get an appointment because they've all gone. So it sets out 4 aims. Enable and empower patients to use tools to monitor and take responsibility for their own health when it's safe to do so. So there have been a number of local pharmacies as well, and services to pharmacies that will add to that. We need to really implement a modern general practice now that so patients can get treatment or be directed to the right person, the right place, the right time on the day of their request. The third is about building capacity within general practice. So there's a lot of actual wasted appointments, believe it or not, within general practice. So, you know, they might be able to get treatment elsewhere, not necessarily from the GP when they call. So the fourth is about cutting bureaucracy, and that's so that the practices can actually focus on their patients' needs rather than all the administrative burden that comes with a running of an everyday general practice. So we've developed a local draft plan in response to this, and that will have final sign-off by our ICB board in March. Absolutely happy to bring that back, Chair, if that is something that you wish to do here. The challenges that general practice face have been that, as I described, the 8 a.m. rush, appointments, clogging up the system, and this in turn has really kind of focused on the general practice morale. The staff of morale has really, really lowered. So they don't have necessarily the capacity to manage the demand. So a number of reasons for this are the older people, there's more older people, there's an increase in that population, and we have more long-term conditions. So we have outpatient backlog. So that in turn brings patients back in to see the GP because they're waiting so long for their hospital appointments as well. So the workforce model's changed, and I know that has been brought here before. Over the last few years, we've implemented additional roles within general practice to free up that GP capacity and shift into that kind of social prescribing element, pharmacy. So obviously the social prescribing we'll come on to later on the agenda. So in terms of our local patient experience, ultimately we want to improve this. And it's part of the measure of our local success of our plan going forward. The good news is that across Staffordshire we've already seen an increase in which is positive in terms of the variance of the patient survey. So we are the only ICB in the West Midlands that have actually improved their patient satisfaction rates. But obviously we want to ensure that there is a local variance. We know that there are pockets of areas that aren't doing so well. We want to focus on those areas so that we can ensure all of our patients across Staffordshire get that positive experience regardless of which practice they are actually registered with. We've got 13% higher number of appointments in general practice since pre-pandemic. That's nearly 73% of these are actually delivered face-to-face, and we are above the national average for this. GP numbers have remained steady actually in our area, believe it or not. We haven't seen a decline in the number of GPs across Staffordshire. And we do have a number of recruitment and retention schemes that support us with this. Our additional roles has meant we now have 474 more staff across Staffordshire and a variety of new roles offering that care to patients. So really, you know, how are we going to improve access? Because that's what's really important, isn't it? So it's fair to say it won't be an overnight fix. You know, we are working on it, but we have that commitment and effort and plans in place that are staggered over across the course of the next year. and those changes will need time to be embedded, and they'll need time then to be measured. So all of our primary care networks, that's our groups of practices in local areas working together, have submitted access improvement plans, and the ICB is working with them and supporting them to implement these. Understanding their information, working better with them to empower their patients, have access to online records is something that actually our practices are doing really well at. So all patients now within Staffordshire can access their medical record online and see the detail that sits behind that. We are ensuring that we have a digital plan, a digitally enabled plan, but obviously we don't want to leave any digital patients not digitally enabled to support them as well. So there's a plan alongside that. So pharmacies have already seen 2,400 appointments since March last year for things like blood pressure checks. A number of new services at local pharmacy level are also just about to be implemented, which include 5 new services. We're implementing cloud-based telephony, so that means the telephone systems will be digitally enabled so that patients, if they can't get through, they will get callbacks, etc., and won't have to listen to an engaged tone or have to be 14th in the queue, for example. We want our GPs and hospitals to work very much together, have that open dialogue and relationship so that they can cut down on the bureaucracy of referring over, please do a prescription, please do a blood test. We want to ensure that they have that collaborative working in place to minimise that disruption to patients and have that open dialogue. We've built in quite a large communication campaign so that the public know where to go for their treatment, what is available to them locally, and how they access it. We have a number of referral pathways now in place also, which we will expand for patients to have self-referrals into services so that they don't have to go through their GP or their local pharmacy to access them. So things like physiotherapy and musculoskeletal services. So I suppose just in conclusion, we have developed our access plan. Some of the information that is within it is included within this report, but the access plan itself is very large, so didn't want to kind of put that document in here today. But our overall aim is to ensure our patients can access what they need when they ask for it. Thank you.
Thank you. And I think that's an aspiration we all want to have. Maybe you could come back to us with the action plan specifically, what the individual actions are with smart timescales to those so that we can see them. I think it's not in here. With committee's permission, there's so much data now. I'm going to suggest, if we're not careful, we're going to dot around so many issues and so many pages that we actually take it page by page, because otherwise we won't really. I think we should do that first and pick up the tactical issues first. And if that leads into a strategic issue, great. If it doesn't, then we'll leave some time for a strategic discussion as well in terms of some of the approaches. So I'm going to start on page 19. Just indicate if you have a question on 19 or a point that you want to pick up off these pages, and then we'll just quickly try and fly through these. So I've moved off 19 and I'm on to 20. Anne Edgeler.
I think I'm looking at the right page where I talk about the deprivation areas. What are we doing to try and correct this?
Thank you for the question. We've actually got a quality improvement framework across Staffordshire, which is just local to us. So what we tend to do is have indicators that are based on inequalities to support our local area in improving them. And we change that every year according to the needs of the local population where that deprivation sits. I don't know whether there's anything that Paul wants to add to that in terms of... No?
No, I don't think so.
Anne, do you want to come back? Okay, so there's a couple of things off this, and it falls off the back of what Anne's asked. First of all, for those districts and boroughs around the table, is there a zoomable map so they can? I mean, they will probably, they will most definitely know where those are, but sometimes it's easier for it to be seen. So first of all, is there a zoomable map? Second of all, are you overlaying across this, some of the discussion we've just had on dentists and access and morbidity and any of those other access to health services? Are you putting that on top of these? And in which case, will that be available for districts and boroughs and all of us to see?
Absolutely. We haven't overlaid that yet, but we will, and absolutely can supply a zoomable map so that district and boroughs can have a look at that in detail.
That'd be really useful. I'm sure everyone around the table would support that. So I moved on to page 21. 22. 23. This is about the range of people who do not attend, which seems to fall in the range of 4 to 6%. So 4 to 6% of appointments that you have available are wasted. Sorry, bring in Keith.
Just wondered if you had any information as to why October seems to be the period of time where there seems to be more increase or whatever. It seems to be the same in each year. The 21, 22 and 23 all seem to be the same. Just seems a little, is it an anomaly or something somewhere? I don't know.
I imagine it's an anomaly.
Yeah.
Okay. And I think it's worth pointing out that for all months of this year, last 12 months, the availability of appointments with primary care has been greater than the previous year. Okay. Page 24. Page 25, sorry, page 25. Page 26. So I've got a question on page 26, and I think it flows through a number of these. I'm less concerned by the GP practices, primary care practices that are above the dotted line. What I'm really concerned about is the ones below the dotted line. And I respect that you don't want to necessarily name those practices. But what are you doing specifically with those practices to drive them above the line?
Thank you. It's a really important question. One of the issues is that within a GP contract is not a specific amount of appointments that has to be delivered through that contract. However, we do apply a kind of BMA recommended guidelines. So we work with our practices on kind of looking at them being above that level, hence that line. We work with individual practices that don't appear to be above the line, and as part of their access improvement plan, we have asked them specifically to look at getting across that line. So we're hoping over the next year or so there will be some movement on that. But I suppose there's the point of some practices won't need to have as many appointments as others, and they might be doing their work slightly differently. But it's understanding that. So I recognise that having practice names against this is quite important for some areas. So it's something that we could look to do, I think. I don't see why it can't be shared.
I think we would welcome that because we will have local experiences. I think the other bit is, it's the correlation of on these graphs, which are really useful, how many of the same names appear in the same places. And I guess that is the piece that you are working on behind the scenes. I made that as an inference, but maybe you could just confirm that, and then I'll bring Janice in.
We would probably suggest that the names of the practices that appear low on some things and other things will be practices that we are aware of and we are either supporting or dealing with from a contractual element.
Thank you for that confirmation. Janice.
Yeah, you may well have preempted part of my question there, because we do have some of that granular detail on page 26. And I can see, I cover Lichfield City North as my county council division, but we can see Lichfield PCN is above the line, Burntwood is below the line. And I dare say there is a significant amount of context into why that is the situation. And I think sometimes it's helpful to have some of that backstory. We don't necessarily need to name names, however, but because of the amount that there's not that many choices to differentiate from, but I think that people need to know.
Okay, I think that's accepted by the sounds of things. Anne Edgeler.
Thank you, Chairman. Yes, looking at these graphs and that, you know, I mean, part of my division is the Stafford South East Division, but mainly concerned looking at Stafford area, how many that, you know, well below the giraffe line. And I'm just wondering if this, because of the increase in the houses that's being built in Stafford, the number of people that's arriving in the area, I'm sorry, I know we're Staffordshire, but it is something that's highlighted in here. And I just wondered if we're looking at that, because the increase of population is very high.
I think it's a relevant point given all of the building that's been done across many of the districts and boroughs.
Yeah, sorry, I think we've moved on to a different slide, so I was looking at the wrong information. So you said that Stafford has less.
I think the point is generally is house building being taken into account?
Absolutely. All of our practice plans are built around, and we work really closely with the local authorities on planning for the future, and we submit kind of 106s in terms of health. We look to expand GP practices where we can. We do have that relationship, so that's very much taken into account.
With pleasure.
Thank you. My understanding is that on planning, that it's got to be, is it 500 houses before you can even look at anything like that? And I know there's patches of area throughout Staffordshire where there's less than 500 houses being built. So, you know, you can get two situations on a planning situation. You've got 300 houses in one place and then 300 houses in another. So therefore, the health situation doesn't come into it. So can you answer that question, please? Thank you.
Yeah, absolutely. We do still work with our local practices and local authority, regardless of whether there were 300 houses or 4,000. So we ensure that our GP practices have the ability to take on additional patients within the local areas where those developments are happening.
You sparked an issue here, Anne, because I've got a whole range of speakers, but it's a really good question. And can I suggest to district and borough councillors that on your Economic Development Scrutiny Committee at a local level, you ask the question very specifically to make sure that we triangulate backwards and ensure that the intention is being delivered on the ground. Because
So
that, I think, is I think that is the issue that Anne's highlighting. Let's go to Kath.
Thank you, Chairman. Just on this subject, you say that, I know that 106 is coming to the scenario, but at the end of the day, a lot of doctors are private practices, and they may not want to increase their build or whatever themselves or capacity. How would you get around that? I mean, do they have to take on extra patients if there's a new house build? Because they are private practices at the end of the day, most of these are. So can you answer that for me, please?
Yeah, GP practices are independent contractors, so they don't directly report work for the NHS, they do report to us. But they've all got open lists, it's part of their contract. They can't close their lists unless they have special permission from us to do so. It's very much within our interest to work with local practices to ensure that they've got the capacity and capability of taking on additional patients when areas are expanding. So we would look at all practices that were in that local area and have conversations with all of them. It's also within their interests if they want to increase their their business profits, essentially, because by taking on more patients, it provides them with more income.
Kathy, okay? Jill.
Thank you, Chairman. I know the Chairman said not to speak about personal experiences, but this morning I called my local practice for an elderly resident, and she was offered an overspill appointment. I haven't heard of this before. Is it something that's commonly used, but which is excellent, but for her, she's 96, and there was no way she could travel 23 miles to her GP appointment. So I just wonder how much information and who are making these answering these calls. Do they have information in front of them? Because otherwise it's a pointless exercise. Thank you, Chairman.
Thanks. There are a number of different services that have been put in place over winter, and that's to support general practices having more capacity so that we lessen the pressure on our A&E. And we do that in a number of ways. Some of the practices will deliver more appointments, so we've got 5,000 additional appointments across the area every week. And we also have a bespoke hub type arrangement as well. So there'll be additional appointments on top of the appointments, on top of the additional appointments at a specific place. However, those travelling arrangements shouldn't be 23 miles. So I think, because I don't know the circumstances of your individual question, I am absolutely happy to catch up with you after this so that we can look into that, because they're not supposed to be over and above a certain mileage, really.
Thank you. And there is still home visits, I seem to think as well. Or have I mistaken that?
Sorry?
Home visits from GPs.
Yeah, GPs should be doing home visits for patients that are, frail, elderly, can't get into the practice. In most areas, there's also an acute visiting service that looks to support GPs with that kind of GP in a car visiting patients at home. So again, if there are any issues you want to kind of personally discuss with us, we'd be happy to help you.
Thank you. Really helpful. Richard Cox.
Thank you, Chairman. Thank you, Anne, for bringing up that question regarding development. I mean, it's a cumulative development that really is what we ought to be talking about, as well as rather large developments. But I find frustration in a sense of trying to answer the questions of, that we need more doctors' surgeries, etc., when obviously the ICB look at it very clearly and say, well, we can expand an existing surgery. I think honesty needs to come into it, because the degree of communication then needs to go out to the general public to understand that conundrum, because they see it clearly as a lack of provision, yet obviously the provision can be serviced within, but it doesn't seem to get out there. And of course the easy pop is that the local authorities are approving this, approving that, etc. Well, actually, obviously, as you say, through Section 106 and so forth, it should be able to round everything off and everybody's going to be happy. It's clear something is wrong, because nobody is happy because of the number of phone calls, the waits, lack of appointments, etc., etc. And so we're never looking to see if we're actually getting on top of it. So it needs a degree of honesty. What is the reasons behind it, in a view of letting the general public know that actually the provision is there, and we're happy with what we've got. I can give instances of where, a developer was quite happy to build a new surgery. Yes, it would determine that you'd have to find doctors to fill it in, and there's a shortage, and there lies a problem. But it's really then taking that other option to hand. So what are you going to be able to do to really have that honest conversation with the general public, not just through local authorities?
Sarah.
I actually take the point, you know, that there needs to be some improved communications, and we will look to do that as part of our communication campaign on access. But we would look to you for support as well in terms of that conversation with the general, you know, with the communities that you come into contact with every day. We, as a general rule, if we look at the capacity within a local area, there's usually not the need to build a new premises, because all of that comes with a new contract. It comes with revenue costs. It's, you know, it's not just a building that somebody's putting up and paying for. It has a consequence in years to come. And like you say, there isn't always the GPs that, you know, want another contract. And so we always look at the local surgeries and ask them about local provision before we consider building new buildings, etc. So that we can focus on those areas where we need to develop new buildings. And there are areas at the moment that are a significant priority for us.
Anything further, Richard? Leona.
Just to add in, so if of course, you know, if we're extending new buildings, that would be costing. But of course, some practices, they have evening appointments, but not all centres offer it. So would we looking in a long term? Is it evening appointments, or those who don't show? Because, you know, in practices they say, you know, how many have not showed up to their appointments? Can we do something to prevent that happening again in regards to no-show?
So we look at a number of things when we're considering. It's not just the number of appointments, it's the number of staff, the size of the building, the estate, the workforce, how many patients are currently registered, what the quality is like, the patient satisfaction rates. So it's a number of things that we would determine, as well as the capacity.
As in my question would be like, you know, are we, instead of doing evening appointments, is that something to look into, or like those who don't turn up? So 3 more appointments for this rush of demand. So how to treat no-show.
I'll take that. I think what you're asking is, are there evening appointments available, or is that something that we can look at? There is actually evening appointments available. So as part of, so general practice core hours are between 8 and 6:30. Actually, what we've also commissioned is what's called enhanced access. So that's additional appointments within the evening and on weekends as well. And that is something that we continue to monitor. We do get really good patient feedback actually in terms of that, particularly from those that work during the day, for example. There's also the bit around, I think you also picked up a point around DNAs, and it's something that was picked up earlier as well. We're doing quite a bit of work around using some behavioural science around this, and actually what you tend to see is that when patients' DNA, you'll see a poster up in the practice saying X number of people DNA'd this month. Actually, what we want to do is flip that around and say, actually, X number of people attended their GP practice this month. Isn't this great? So flipping some of those behavioural communications to patients. So we're doing quite a lot of work that sits in the background in terms of that as well. I think that was part of your question.
It's mainly about
Thank you. And just DNA is did not attend, just for the records. Sorry, Leona.
So, what I mentioned was that people who don't show up to appointments, how can we free those up for those who really need it instead?
Okay, can I bring in Baz and then we'll take the two together, please?
Yeah, thank you. I just wanted to pick up that point about the enhanced appointments. They have been received really, really well. All the feedback we get from, as a Health Watch, from residents is that they've been really, really helpful for those people that are working. I think the only thing I would say is that if there's a problem with that 8 a.m. rush, because some GP surgeries seem to be good at times and not so good at other times for some reason. So some people are saying, oh, they used to be all right, but they're not all right now. But then appointments are given as part of the enhanced instead. So it's almost pushing the burden off what could have been done in the daytime onto those evening ones. And we don't want to push the problem across. So I'll leave it there.
Thank you. Bernard, can I bring you in? Leonie, you have finished, haven't you? Yeah, Bernard.
Thank you, Chair. I'm looking at the governance mind map, if that's what it is, and I just want to bring the conversation around to, there's no mention, and I haven't heard you say anything about whether you value the PPG. Do you think the PPG is adding value? I am a member of a PPG in Burton, so I'll make that declaration now. And I have to say that the practice manager plays a big part in keeping that show on the road. Now, what reign have you got over that, and are you looking to enhance what's going on in a PPG in a communication strategy, really?
Thank you. PPGs are extremely important to us. As part of that, you know, the patient, the communities, and hearing from them, we encourage all practices to have a PPG, whether in whatever form that looks like is determined by them and their populations. Within our primary care network access plans, we have in fact asked for PPGs to ensure that everyone has a PPG. And our communications team work very closely with our kind of districts on what comes back from those PPGs as well, so we can hear from our communities.
Can I just make a further point? Because PPGs is very reliant on patients coming forward and wanting to be part of a PPG. I'd really like, as part of this programme, to be promoting that, but actually, how do we get wider voices as well? So currently, the National GP Patient Survey is out for people to fill in. What I would really like is to encourage, if you're a patient, anybody watching this, if you're a patient and you've received that survey, please fill it in, because that forms part of the developmental work that we are doing with general practice.
Thank you. And presumably you would encourage any PPG who was below the dotted red lines and all of these things to be asking the right questions. Bernard, anything further on this one?
No, that's really reassuring, and thank you very much. And let's hope we can keep this show on the road. Thank you.
Thanks. Kath, you on this issue, or are you on a...
Just to make a comment, if you don't mind, Chairman, please. Thank you. Just to say that, just going back to what you mentioned about the house bill that Anne mentioned earlier, that we have, some are small, some are large. It's the communication between the general public that I think needs sorting, because they see all this house build, but they don't see any different service within their GP practice. So where does this money, do you monitor where all this money, if they do get one house, I know it's not a lot, but where do you monitor where this goes to? If it's to employ more staff or more doctors or anything. I just think it's important that the message gets out there to the public, because when they want to make an appointment and they can't get one, oh, it's because we've had all this new house build, we can't get an appointment. So I think your communication needs to be out there and not just online, wherever you can make it, even if it's in the GP surgeries themselves, when people actually attend. Thank you.
Thank you.
Absolutely take your point, and I think that is something that we've heard loud and clear around that improved communications with our public, so that they know what services have been invested in and what is available to them. Thank you.
Thank you, useful. Anne Edgeler.
Thank you, Chairman. I just want to pick up on Bernard's point, actually, because I'm also a member of the PPG in my area. But when I mentioned to them that the ICB are really interested in keeping in... Well, what information do we get from them? You know, that they shot back at me. You know, so do the ICB give any information to the PPGs that we know are out there? Thank you.
I think we don't give information to the PPG from an ICB perspective. However, we can build that into our communication plan going forward.
Thank you, Chairman. I think that will be helpful.
And And I think just to say, Chair, as well, that we do have some quite proactive PPGs who will send us, I mean, we've just gone through for one particular one, a list of questions that they've asked us that we respond to, and then they do follow-up questions to say, well, you told us this last time, where are we? So some of them are very proactive, and we're always willing to try to answer the questions that they've got in terms of that, but we're probably not as good at pushing the information out to them as maybe we could be.
Really useful. Thank you. Chris.
Yes, thank you. I did have a series of questions, but I'll talk to the PPG one at the moment. We had a meeting of Health Watch organisations from across the region, East and West Midlands, and one of the key agenda items was PPGs, their effectiveness and their impact, because there are quite a number of practices that have PPGs, but that's not the same thing as listening to them. They're actually ticking a box to say we've got a PPG. So what we're going to be looking at as Health Watch across the region is what is needed to demonstrate that PPGs add value to general practice. They add value to the members of the PPG, and they add values to the constituency, to the patient group of that practice. And we'd be very happy, I think, because Baz was there, we'd be very happy to come back with the findings of that, because it's an agenda item at our next Health Watch meeting. And we've invited the National Association for Patient Participation to come along and to talk about the work that they've been doing right across the country to support PPGs, because we feel it's a really important part of patient voice being heard.
Thank you, Chris. Really useful. It sounds like there's an open door at the ICB?
Absolutely. I mean, you know, that's so right. You might have a PPG, but are the communities actually being listened to by the practice? And that's really important. And we'd be more than happy to work with colleagues and Health Watch to support this piece of work. It's really important.
Thank you. That's really useful. Thank you. I'm going to go back to pages again now. I know we sort of slipped off the pages, but we will try and get through them. Just before we do, however, just on that original slide that Anne Edgeler talked about in terms of deprivation slide, presumably we'll start mapping on, you know, the ages of patient profiles, because, you know, I would guess that often GP appointments relate to the age of patients, and then we'll start doing a bit more of the other more sophisticated mapping work, and then try and use regression testing to take the individual slides you've given us and actually look at multiple different factors to try and make sure there is an appropriate support and service for the residents of Staffordshire. I'm assuming that's where you're going to go to. This is just work in progress, and that's one of the next steps.
And it's very much part of population health management as well, in terms of linking some of those comorbidities together, understanding what we know about a population, then, as you say, working that back to say, have we got the right services in place to be able to do the prevention, to look after people, to refer people, etc. So it's very much that, sort of go to that and then go back. Yep.
Yeah, thank you. Because obviously with 140 practices across Staffordshire, you know, you've got a huge amount of variability, some really great practices, and we should acknowledge that, as well as the sort of the stuff that Richard was talking about. Okay, page 26, page 27. Charlotte, which one are you on? Okay, I'll go on to 28. Good, I'm glad you're keeping me honest.
These graphs from 28 onwards, they demonstrate that Newcastle South and North appear at the top of most of these graphs. So what are they doing right by comparison with other GP practices? And what are you doing to share that good practice? Now, one of the points you make in the paper, not quite sure where, is that the amount of NHS funding to GPs has gone down from 11% to 8%. Now, from what I know of local GPs who have moved in and out of the hospital sector into general practice, is that very often doctors will move into hospitals if, for instance, they get a better rate of pay, better conditions. And are you therefore seeing that you're getting doctors moving into hospital care rather than GPs if they perceive that as NHS gatekeepers, they are being underfunded by comparison with the acute sector.
So your first question was around kind of sharing learning and experiences. So we actually have a primary care network collaborative every month where the staff from the practices attend and share their learning experiences and the things that are going well. So that's a forum that that looks to have that peer support in place, if you like. The other thing that we do is we have a webinar with GP practices every month. So what we share on there are new things that are coming out, but equally we share experiences and learning in that setting as well, so that practices can improve the way that they work or the way that they operate. And as part of those PCN development access plans, we want to be able to bring the rest of those PCNs up to the same level as what you refer to as the highest. So does that answer that kind of?
Well, I was interested to know what they've actually done. I mean, you presumably have identified that they are high scoring. So what are they doing which others aren't?
Do you want me to? There'll be a number of things. So bearing in mind we've got 25 PCNs and 142 practices, we could probably reel off quite a lot of stuff within this section here, but there is particular key points of learning that is shared. So for example, it might be how they manage their telephone system, which is one of the things that you'll see within the whole improvement plan, or it might be how they engage with their patients. So there could be multiple things. I think what Sarah's trying to say is that we share those things as part of the webinars and as part of our PCN collaborative to try and share that really good practice.
They stand out, and I just thought that you might want to share with the committee, what they're doing which other practices aren't.
Yeah. You also picked up GPs moving around our evidence shows that we've retained GPs in Staffordshire. Our GP numbers haven't actually changed. We don't have any evidence of GPs moving into hospital care at all. We have a number of retention schemes, as I mentioned earlier, and we've been able to bring retiring GPs back into our system, in fact, by support and development and part of that training.
Thank you. Maybe we'll keep that, your question under review, and I think it's a good suggestion at some stage whether that's something we want to shine a light on and dig deeper into the next level. But without the data, which is my original point on here, without the data we would never get to that sort of point, so really useful, thank you. Just a follow-up point, you mentioned phone systems. And I'm inordinately surprised at the speed of adoption or slowness of adoption. Cloud telephony, you can turn on and turn off. 2 years after the end of the pandemic, I'm still staggered the number of people who have not invested, because it's not a major significant cost to invest in cloud telephony. Maybe there is a reason why people have chosen not to invest in it, but it would certainly remove many of the frustrations that their residents have. Is there a better messaging, or have I got this completely wrong?
I think possibly the cost would have been something that would have made general practice not want to invest. However, there is national funding now, so they can access that in order to change their systems. I think some of the complexities are around contracts that they may have entered with suppliers for many, many years. So it's costly and time-consuming trying to get out of those contracts. So I think that's why it's taking some time to get everybody on a cloud-based system.
albeit, you know, they're in a customer business, and actually the biggest frustration their customers have is being able to do the simplest of things, not the clever stuff, which is the diagnosis, just the simplest of things. Maybe we'll just move on. Page 29, page 30, page 31, 32, 33, 34. Anything in the 30s? Janice, thank you.
Chair, I have a number of questions, and I've gone through the pages now. So I was on 47 at one point, so, you know, you'll have to bear with me a little. Telephony was definitely one of mine, because I noticed that some of those are on analogue, and I appreciate exactly what you've just said. Given the fact that there is that funding support now, and they are in a sort of client service-based area, is there actually a deadline? I know Chair mentioned earlier on about smart objectives being put, but is there a definite time frame where we can anticipate that even those that are on analogue systems might even go into digital, let alone cloud-based? I have some more questions.
We will have a plan. It will be in the plan for each individual practice in terms of the dates. So we'll be happy to share that with you, so you can actually see which practices are still on analogue and which are on digital, and when their actual dates are for changing over.
Yeah, thank you. And for me, it is those smart objectives, those deadlines to say, okay, this has got to be the day when it happens by. Not least because, going on to my next point, that we see between 30 and 50% are movable appointments, that they could actually be redirected to somebody else, which I think is a phenomenal figure. And it goes to the signposting. And is that signposting through making a telephone call and getting that instruction at that point? Or is it going onto the app and being able to look at the functionality that we've got there? So I think as far as being able to best allocate those, a bit more detail, I think would be helpful as to how that signposting, because I think we've talked about this, and I appreciate the time that it does take, but I think now it's knowing where we've got those timetables in place is part of the first question. And then the second part is the patient preference also a consideration in there? Because I appreciate that if you've got a distressing illness that you want to speak to the doctor, but actually it may be the practice nurse that may be best. It may even be the pharmacist, and how that process happens to try and make sure that we are linking up the patient with the best person at that time to them to be able to do that. So the patient preference, I think, is also something that I'm curious about.
Yeah, I think patient preference is really important, particularly when it comes to continuity of care. And that has to be that kind of conversation at that, almost the care navigation conversation. But absolutely, patient preference in terms of whether they want to have an online conversation with a GP, or they want a telephone conversation, or they want to actually be seen face-to-face, has to be taken into account, and the practices must take that into account as well. It's the same for patients that are not digitally enabled and don't want to look online, you know, so all of those factors need to be considered when treating that individual and their own preferences.
Thank you. Janice?
Yeah, and just as far as the time frames again for some of those activities and putting those in place to make sure that we are getting the most effective linking to the patient to the right provider, I think is also something that I mentioned just as well for those, an indication of, please.
I think that's going to be an ongoing process. Some of this is around building confidence in the whole care navigation signposting process really for patients, so that they know what it means for them, who are they going to be signposted to, and building confidence in those onward people, because as you know, lots of people, when they ring up, they want to see their GP, and actually that might not be the best place for that patient. So what I would say is timescales are not fixed for some of that, but actually we're doing quite a lot of work at the moment in terms of training around care navigation and signposting, and almost building up that kind of directory of service of where patients can be signposted to. And that's not just internally within general practice, it could be anywhere outwards, community pharmacy, voluntary. So I think that will take time, but we're on a trajectory, I think.
Thank you. Anne.
Thank you very much, Chairman. I'm sorry, I've forgotten which number you're on, but I'm on page 38. And at the bottom of page 38, it's an increase to additional roles in general practice. And the bit I'm interested in is the mental health practitioner. You know, and where are we going with that? Because knowing that mental health is a major problem now and a growing problem throughout the country, not just in Staffordshire. So, you know, if they haven't got a mental health practitioner in that practice, do the GPs know where to signpost people for the mental health problems? Because I've known in the past there has been problems. So if you could clarify those answers for me, I would appreciate it. Thank you.
It's my understanding now that all but one primary care network across Staffordshire has a mental health worker. Those that don't, and even in some other scenarios actually where it might not be appropriate for a patient to be referred to those individuals in terms of what they're qualified to do, we have mental health services and they are across with Midlands Partnership Foundation Trust. So all of our GPs are aware of all the services on offer and how they can refer patients into those services.
Richard.
Thank you, Chairman. There's many of the graphs that we're seeing in terms of the ease of getting through by phone and practice website and so forth. But when we actually look at those figures, they're pretty, in many ways, not good, are they? And obviously any figure that's provided, there should always be an achievement to do better. And obviously probably enhancing actually what Charlotte said earlier, it's about where's the good practice that can be shared where there's poor practice, because there's evidently, if you look at it, there is poor practice, and that poor practice, it affects the patient, doesn't it? And so the question is really, what are you doing? And I think it goes in line with what Charlotte is saying. In an overall capacity, there needs to be an overall improvement. You know, I mean, if I was to quote my own surgery, I'm happy with it, of recent, but I'm not too sure they should be saying that they're still under COVID restrictions, you know, and I think it's that may be, you know, this kind of, let's get positive about things rather than negative, because the positive will drive the betterment, in my opinion. If we still hang on to what is negative, it'll only just drag you down to levels, because what that will create is then the new normal. And of course, that was a phrase that was used during the COVID, that we will have a new normal. Well, that new normal can't be down at 40, 50%, 60%, 70%. It has got to be higher. So we've got to address that, and collectively with the various areas. And so, not necessarily a question there as such, but I think it's more of a plea.
Paul?
I mean, just I think, Chair, just to say that there are 2 or 3 levels that we need to improve sort of performance and sort of achievements by. One is very much universal. So one is, how do we lift the whole bar? But then there's also, how do we support those practices to linking into the earlier question about good practice. So whereas somebody made an innovation, done something different, it's exciting, we can really make a difference. And then we've also got those who need specific support because they've fallen down on one area or another. Some of those will be picked up as starkly as by CQC when they come round and do their inspections, and we'll support those practices. We've got a GP support team that will go out and will work with practices. So I think it's 3 levels. You know, it's that one about universal, it's one about good sharing good practice, but it's also one about supporting those who struggle. And across all of our practices, there will always be issues of new good practice coming. There will always be issues where somebody is struggling for one reason or another. They've lost staff, something's happened or whatever, where we need to go and support them. So it's that constant work, I think, about looking to overall raise the standard, but tackling those two areas of good practice and specific support.
Thank you. Jill.
Thank you, Chairman. Page 38 again with the increase to additional roles in general practice. And I'd like to focus on the pharmacists. I think it's an absolutely great idea that pharmacists now are more heavily involved. I personally, in my volunteer role, have benefited from the role of pharmacists. Parents panicking over a child and they can't get an immediate appointment and they can't afford to get to A&E, and a really elderly person who's fretting because they can't get through on the phone. It's absolutely brilliant, but what I do really feel concerned about, and this is by general observation on a number of occasions, what on earth is happening to prescriptions? Why can't they get the prescriptions right? The amount of times that I've had to go back for someone and say, you haven't fulfilled this prescription fully. And then it's, if they're having the prescriptions delivered, you'll have to wait a number of days. Well, sometimes patients can't wait a number of days. Maybe it's blood pressure medication. They need it if they've run out through their own fault. It seems quite a common fault. And I've noticed this in 3 chemists with 2 GP surgeries in my division. So is it a general problem, or what is happening? And every time the doctor blames the pharmacist and the pharmacist blames the GP practice.
There shouldn't be a general problem with prescriptions. It's all electronic. It does depend on how the patient actually requests their repeat prescription, because there are a significant different amount of methods in which to do, which can be all kind of confusing, if I'm honest. So some practices ask for a 48-hour response. It has to be in writing, or it needs to be ordered online. But there is equally some pharmacies that will take your request for a repeat prescription and put it through to the GP practice for you. So I think this is more about kind of building the effective relationships and getting away from the blaming each other. At the end of the day, the patient needs their prescription. Somebody is responsible for giving it to them. Just sort it out between yourselves and actually give the patient what they need. And I think that's where we need to get to. So we are having, because we are now responsible for, as we've talked about, pharmacy, optom and dentistry as part of that contracting, we're going to be able to get to a point where we're going to support community and primary care to come together better in those relationships, particularly in particular areas where they're quite close to a particular pharmacy. Because at the end of the day, we just want the patients to have their meds. But your pharmacy comment, thank you for that. I think there's been lots of benefit in terms of the additional workforce in general practice, and it's really valued.
Please.
Thank you for that. I did also want to add that, yet again, observations how tiny most of the chemists are. And we have shelves and racks of prescription bags being ready. We've got someone being consulted, the pharmacist consulting with patients. We've got queues of people, and this is most of the day, every day. How long before those pharmacies crumble and need to move to new premises? Is that something that's being considered, or is that too far down the line?
I think it's a bit far down the line, but equally, there has to be an understanding of who's responsible for the estate and things like that of pharmacy. But we are supporting the workforce. We know that there is a pharmacy workforce shortage, and we're working with all our areas on trying to support that going forward.
Thank you. I'd certainly echo Jill's comments in terms of community pharmacies. Certainly echo that. I also note the tone and language of aspiration that you gave in the answer you gave to Jill. So I hope that that ripples through the whole of the organisation. Just before we move on from pages 30 to 40, I note that on page 31 there's a clear hotspot for around Burton in terms of ease of getting through. Maybe we could just take that as an offline conversation with the relevant Burton members, because I'm sure that's of concern for them, and I'm sure there's an answer to that. Maybe the phone lines haven't made it out that far. Maybe that's the issue. Okay, so I'm in the range 30 to 40. We're now into the range 40 to 50. So I've got a question in terms of page 46. There's a whole range of metrics and the primary care dashboard. No numbers with those. I'm assuming that's something which is in construction. Or is that just my...
Yeah, that's correct.
Yeah.
Thank you. When will that be constructed?
That's part of the access plan that we've developed that will go to our ICB board in March. That will form part of the mechanisms that support that. So it's going to be after the March. So once the plan has been signed off, then so will these metrics.
Perfect. Good strand of activity all coming together at the same stage. Nice to see. Okay, I think that takes us through the numbers. More now on to page 49, which is the presentation itself. Is there anything specifically that members more widely want to pick up? This is more of the strategic element. So is there questions that members just want to pick up or follow up from previous discussions? We've obviously seen primary care access a number of times over the last couple of years. Okay, I'm going to ask one in terms of page 52. Have we got analysis which is looking at a proactive approach to those frequent users of services? So, for example, nursing homes quite often is a source. I've talked previously about whether proactively you should be sending GPs into nursing homes to pick up stuff in advance. People deteriorate very quickly often when you're at the most vulnerable stage of life. And equally, is the work being done on a local level about those most frequent users of services and see whether they are the most appropriate? I know that ties into the social prescribing discussion, but is there analysis being done sufficiently here?
Yes, I think that kind of fits in with personalised care. So in terms of the work around care homes, nursing homes, we've actually got a whole piece of work going on that is a system piece of work associated with this, so it all links together, and the primary care element of it is ensuring that our residents in homes are receiving the care that they need. The frequent attenders, that will be done more at a kind of practice level, just to look at what those patients are and how we can best support them, and that will certainly sometimes link in to the social prescribing piece. So it's dependent on the individual's needs and why they're actually frequently attending.
Thank you, Paul.
Just to come in, Chair, as well, just to say that the care home piece of work, it's a big piece of work. It is being done right across the whole system. The care home group is actually chaired by Richard Harling from Staffordshire County Council, is chairing that. So it's very much across local authorities as well, because obviously local authorities are big users of commissioners of care homes and so on. So we do that jointly together. In terms of looking at sort of the frequent flyers and so on. Again, I come back to population health management. So we recently did a big piece of work around the over 75 population and admissions to hospital and attendances at hospital of the over 75 population, why that was happening, where they were coming from, either clusters in the local population, clusters from care homes, clusters with particular conditions, which would help us to understand what we need to put in place and so on. So again, huge piece of work looking at that over 75 population across the whole of the area, and some fascinating figures within that. It comes back to a question that was asked earlier about housebound patients and needing home visits and so on. So we looked at housebound, and there's a particular piece of work we need to do about that to make sure that they are getting equal access to the appropriate healthcare that they need, in the same that care home residents do. So.
Yeah, absolutely, because it's not just equal access, it's also they're the most vulnerable and find it the most difficult. But thank you. Just looking around the room in terms of other questions that people want to pick up. So on the basis that no one does, I will carry on. Just in terms of page 56, it talks a bit about drivers and a couple of changing workforce models and things like that. What other models for GP, what other models for primary care are you reviewing? And I'll give an example before people think I've gone completely mad. Someone like Royal Wolverhampton Trust employ their own GPs within, have their own practices, 17 I think, within their trust. So what other models are you looking at and have considered?
So with GPs being independent contractors, there are a number of GPs locally that have decided to go into partnership, if you like, with either mental health trusts or acute trusts, as you've just suggested, Chair. And it is up to them. So we can't influence them in any way, shape or form. There are benefits to them doing that. So what it provides them with is a bigger resource in terms of governance and staffing and support around resilience, is what I would say. But we wouldn't have a specific strategy from an ICB perspective, because we would not want to influence the GP being an independent model. So, you know, that's what the national drivers are in terms of that being the case. But we would never not allow a GP practice to do whatever they felt was right for their population of patients. I hope that makes sense.
Yeah, I think your point is about not disenfranchising your existing primary care practices. Understand that. But equally, there may be alternative models. Paul?
And just to say, of course, that where we do work with practices collective is the primary care network level, where practices are increasingly coming together to look at what they might do together. And so I think there are these sort of models coming out in terms of that. And again, this is where we learn from other places and we share. We can't push practices to do something, but we can share other models so that they're aware of what other models might be.
Absolutely, and there'll be practices who can't take on a full-time role who could share across two practices a part-time role. Absolutely, and that was nice to hear. Thank you. I'm looking round the room. Chris.
Yes, thank you, Chair. I was looking at drivers, as you were, and this is a system under stress, and the fundamental reason for the stress is that there is an imbalance between the demands being placed on the system and its capacity to respond. And if you look at the constituent parts of demand, it quickly becomes very clear the role that demographics has to play. So we had for a number of years an increase in lifespan, and it increased steadily year on year on year. But the increase in healthy lifespan, in which people did not require that clinical support, was slower. And so that meant people were living longer and longer with long-term conditions, and the gap continued to grow. I don't know whether it's a good thing or a bad thing, but lifespan is beginning to fall now. It's leveled off, it's beginning to fall. So perhaps it'll clear itself up in time. But I think what if you look at that imbalance that's there, I think the element that we tend not to pick up on is we do talk about the access to GP appointments. We don't talk about how effective that process is, how effective that GP process is. And if the process is not effective, then people tend to become what's being called frequent flyers, because they come back again and again because the appointment did not resolve the issues that they had. And I think one of the examples of that is what National Patient Voices has been calling the referrals black hole, in that somebody gets referred from a GP surgery and then nothing further is heard. And in some cases, the one that I'm dealing with at the moment, he had a potential stage 4 cancer diagnosis in March and has heard nothing further since. Now, people cannot live under those uncertainties. So I think there are issues about how effective that is, how effective referrals are. Pharmacy is a system under stress. And it isn't just about pharmacies closing, it's also about a shortage of certain medications. So I think the NHS is very good at measuring the number of appointments that it's both giving and missing. What it's less good at is what is the impact of that? What is the difference in patient experience and patient outcomes because of those stresses? And I think that's the bit of work that I think still needs to happen so we can reach a more humane conclusion about what we need to do next in response to this crisis.
I think Paul wants to come in, I think.
I'm happy to come in, Chair. So I think there's a few points in there. Where we started at, I think, in there was the healthy life expectancy as opposed to the overall life expectancy. And Chris is absolutely right. There has been, that gap has increased. COVID has had quite a role to play in that. So COVID has caused all sorts of issues in terms of system pressures, people's health, etc. And there's that increasing gap. We are working at the moment on a new long-term condition strategy about how we bring those together. And I know there have been a number of public events. I think we've been a little bit disappointed at the numbers that we've been able to attract. That's probably our fault because we haven't publicised them properly and so on. But we are very much looking at that in terms of the long-term conditions. In terms of that optimum care, I guess, part of that is what we're trying to do with the alternative roles in general practice in terms of getting somebody to see the right person. I'm a huge supporter of community pharmacy and the pharmacy agenda, and I think having the pharmacists in general practice do make a huge difference. An awful lot sometimes of people being maybe not optimised is due to the medication that they're on, either multiple medication, the medication could be changed, etc. And that's particularly as you get older as well. There is a tendency to increase medication when actually we probably want to reduce the medication. I think where we're seeing issues in terms of referral, particularly around cancer referral, there shouldn't be an issue in terms of referring somebody. If they're on a fast-track cancer pathway, they should be referred within the timescale. Yes, there are pressures within the system in terms of getting there, but that shouldn't excuse us not having the right communication in place, and very happy to work with you if there are specific examples of that.
Absolutely. Chris?
Yes, encouraged by that. In terms of communication, that is the key. If people are waiting, then communication during that wait is crucial. And I think an example of where we haven't quite got that right is the pod system, which is being discontinued on the 31st of March. It was introduced with very little consultation. Now it appears to be being withdrawn with very little consultation. And we need to learn the lessons from that because people are confused.
Okay, thank you. David is going to come in, but whilst he's just about to do that, let me just make a couple of points. First of all, interesting stat on page 60, 41% of appointments are booked on the same day, which I wouldn't have thought would have been the case, which is interesting. And I note that page 62 is very Marmot-esque. and and sort of picks up Chris's point and is pleasing to see, because we're beginning to move from just an input focus to an output focus. And I think for districts and boroughs, what you will see as a direction of travel is some greater stats coming out, and we'll discuss that in the later section on the report, because I'm sure you will be interested at a local level as to those areas that are of concern to your residents and impacting on their healthy lifestyles. David, are you with us now?
Yeah, thank you. So it's a follow-on from the discussions around the changing workforce model on the drivers page. I'm just interested in what further we're doing to recruit and retain our precious GPs. And I've got a follow-up question to that as well after that, if that's okay.
As I said earlier on, we have a number of recruitment and retention schemes across Staffordshire. I'm happy to forward on what those schemes look like to this committee.
Thank you. And my follow-up is around the additional roles, especially physician associates. If we've got a lack of GPs, those staff groups and my staff group, including physiotherapists, need increased supervision to do those roles. So I'm wondering, have we got plans in place to ensure that they have timely and good supervision, so we have good quality patient care?
So there are a number of things already in place for the additional roles. There are staff networks. They have access to the staff training hub, so their education is followed up on. As far as supervision goes, at the moment, the only supervision that is available to those staffing roles is the GP. However, if we free up more GP capacity, it allows more of those roles to come into place. So, I think even based on one of the other comments that was made earlier, I was looking at, a study that was done at London South Bank University, and it is included within your pack on page 58. 40% of GP appointments were found to be that they were unnecessary, basically. I don't like to use the word inappropriate, because patients' needs are the most important thing at the end of the day. But that's where, if we free up some of the GP's capacity, they'll have more of a, I suppose, what you'd find a consultant role within a hospital and the supervision of the staff, but still be able to play that key clinical role in the future.
Thank you. And just to add, I think we need to be careful with language, especially using frequent flyers in this chamber. It's a slightly prerogative term. If someone's frequently accessing care, there's probably a reason for that. And so we shouldn't sort of brand patients as being problem patients just because they access services. There's lots of reasons why. That's it from me. Thanks.
Okay, thank you. Good morning, Thomas. Afternoon.
Thank you. Yes, I want to come back on the point you mentioned there about basically patients misusing the GP, essentially, or overusing it. A lot of that is because the system, wherever you look at, is stretched. So you can call 111. Sometimes you can take ages to get through. You can be sat in there for ages. Right? They'll tell you to go somewhere. You can't get in there. You might go to A&E. If you've got a little child, for example, go to A&E. You sat there for 2 hours, and the waiting time keeps going up. You're going to be there 7-8 hours. So what do? You go home, wait till the morning, call the GP. So sometimes it's not the patient, it's the fact that everywhere you look, it's stretching, you just can't get in. So I think that's why people are probably going there more than they used to. I wouldn't necessarily say it's the patient, it's the way the system is at the moment. It's just a comment.
Do you want to respond, Sarah?
Sometimes I don't think it's the system. It's the way that the system operates, and patients not having the right levels of education and communication, and that's partly, what we need to do as part of this access programme. That communication is really, really important in terms of allowing patients to go to the right place or call the right place at the right time. I don't necessarily, I wouldn't call patients inappropriately using any of our NHS services, because at the end of the day, you just want the care that you think you need at that time. And a problem that might be urgent to you might not seem urgent to a GP, but it's down to an individual, isn't it, and their perspective at the end of the day.
Did you want to come back, Thomas?
Yeah, I did. I think, again, a gentleman over there mentioned a provocative term. Saying it's about education is a bit provocative as well. I certainly don't need educating on the system. And I'll give you an example. I often, to try and help speed up the process, it takes so long. Like my wife, for example, has to take a medication every single day for the rest of her life. To speed it up, I'll go and have a private blood test, take the blood result in to try and speed it up. The other day, we had an example where they were saying, we can't use this, you've got to come in and book an appointment. I went to the appointment, we got one a week on Thursday. All right, so it's going to stay without a life-saving medication for a week and a half. So what do? You end up finding other ways and going to other parts of the system. Not education at all. Certainly not in the case I gave you there. So I think we need to be careful if we're basically saying it's the patient's fault.
Maybe education was the wrong term, so apologies for that. I suppose what I meant was it's our responsibility to ensure our patients know where to go for what. That's kind of what I meant as part of the...
Thank you, Sarah. And obviously, no respect was meant in terms of frequent flyers, because frankly, I'm clear that everyone's looking for solutions to patients' problems and how best to serve them. So I understand that. Okay, I think we can move on from this report, but I think in doing so, do we want to note that it's work in progress and it's going in a positive direction? Is that a sensible starting point? Do we also want to note the opportunities to correlate some of the data better and to drive potential improvements to the variety of performance in primary care, but also note some of the progress made with community pharmacy initiatives and telephony initiatives, and the importance of the role of PPGs. Are those sort of the salient bits? And then the next question is, we know there is some more work that the ICS is doing in this area. It has been one of our key issues for our residents over the last 2 years. I think we can see tangible progress, in fairness, and there's a demonstration of that in front of us. But when do we want to see this come back as an issue? Do we want to wait until the ICS has pulled together their metrics and their strategy, which has gone through their boards, see it back in the summer? Is that a sensible... Okay, thank you. Are you staying with us? Thank you. Apologies for your diary crashing. That, I think, moves us on to page 71, on to social prescribing. Can I suggest that we probably do want to try and guillotine the meeting at 1, so maybe 5 minutes each party, and then we'll take the papers as they are. Is that fair? Who wants to start? Sarah, do you want to start, given that you seem to be first in my pack, or do you want a breathing space to pass the baton?
That's fine. I can present, and then colleagues can say whatever they want to add at the end. That's absolutely fine. So I'm sure most of you are aware that social prescribers have actually been embedded within our primary care networks now for a number of years. This started obviously as part of that additional roles into primary care as part of a national contract. And primary care were able to either employ their own person and however they saw fit, or they could work together with the voluntary sector. There is a mixed model in Staffordshire, so perhaps some PCNs have employed their own social prescribers, some have done that through the voluntary sector and employed them. And obviously there are benefits to these roles actually being delivered with and alongside the voluntary sector. And I'm sure Gary will kind of back me up on that later on. So they're employed to work proactively, improve things for patients that have been perhaps identified as, so let's not use the term that's been used earlier. So they might have a high volume of attendances, for example, within primary care setting. So these roles are asked to work with these individuals, to understand their needs, and that could be anything. It includes that they might be lonely, they might be isolated, and they need that family support, additional support, and it might not necessarily be a health need that they have. So all of our primary care networks have social prescribers employed with them now, and there are actually the equivalent of 41 full-time roles in Staffordshire and Stoke-on-Trent. So apologies that I couldn't break down the Staffordshire element of that for you today. The NHS long-term plan hopes to have 9,000 of these posts across England by 2036. So that's quite significant. So there's no doubt the benefits that these roles have for our populations. There are some facts and figures within the report, but they're based on targets really more than anything. And it's important to note that the number of referrals that have been made by social prescribers between 22 and 23 was 16,786 referrals. And in 23-24, so up from April up to November, 12,123. PCNs have collected qualitative data relating to the numbers and the kind of the sources of referrals, and PCNs have kind of looked at experience questionnaires for patients to form improvements and the way that they work with their social prescribing and their populations. There are several case studies towards the end of the paper. The members of staff are supported, and I think I referred to this earlier when we were talking about workforce. They're supported by the Staffordshire Training Hub, so they have training and development through that. They also have access to psychological health and well-being as part of our ICS offer. And the things that we really need to kind of plan to support in this work going forward are trying to gain more insight and collect more data about the outcomes, and I think we've talked about outcomes a number of times, exploring how we support them better to supervise them, and ensuring that we have that awareness through our training hub and making so that they are aware of what support is offered to them as well. So I know that colleagues are here from Support Staffordshire as well, Chair, so they may have something else to add.
Absolutely. Thank you, Sarah. We will hand over to Gary and to Sarah if we can, and apologies that it's taken us 2.5 hours to get to this point, but good to see you.
Thank you, Chair. So yes, Gary Jones from Support Staffordshire and my colleague Sarah Maxfield. Overall, social prescribing in primary care has been extremely positive, I think, experience, both for the link workers, for the existing staff within primary care, and of course, most importantly, for the patients. So I won't go into any depth about all of the positives. I will just pick up on 4 specific challenges that I'd like to highlight, please. So the first one is around the moment in time that we're currently at in terms of contracting is providing quite a significant amount of uncertainty at the moment, because we don't yet have the detail around the contracting arrangements that will apply from the 1st of April, just in a few weeks' time. And associated with that is the financial position of the contracting arrangements, in particular in relation to when it's outsourced to a VCSE provider, because the figure there hasn't changed in 5 years. There's been no inflationary uplift whatsoever. That is set by a national contract, though, rather than by the ICB locally. The second thing is around system join-up, or sometimes lack of system join-up. So whilst there's very good provision in primary care, there isn't the same sort of provision in secondary and community care, and that is beginning to show. The third is around the individual worker support, so clinical supervision and caseload. There are significant pressures from the caseloads in a number, if not the majority, of PCNs, and access to clinical supervision has proved to be quite a significant problem. And then finally, I'd just touch upon if we extend the metaphor from the prescribing to the prescriptions, the demand that this then generates and creates out there in communities, very often within the wider voluntary sector, not exclusively. It also impacts upon local government and other service providers as well. And certainly there is great demand there, and some of those services are beginning to articulate that they cannot cope with the additional demand that's being generated by social prescribing. So those would be the sort of four sort of areas of concern or challenge, but I would say it's in a context of it overall having been a very positive experience.
Thank you, Gary. Can I just check with Paul Northcote? Paul, do you want, I know that, that the supportive families, the, have I got that title right? Supportive communities even, is not a deliberate social prescribing model, but clearly the County Council has a role and is doing active work in this. And clearly there is some paperwork on this. Do you want to say a few words related to that? With the caveat that clearly it is not a direct social prescribing initiative. Is that fair?
Yeah, you're quite correct, Chair. This paper is basically to show to members that the capacity is there in the Staffordshire County Council, the opportunities that are there in terms of the supportive communities programme. But it's fair to say that there's more work to be done in terms of how we work collaboratively to align supporting communities programme to the NHS social prescribing approach, which we've been a little bit unclear about what exactly is that, because of the variance in GP surgeries, how they've applied that model as it exists. But it's clear that we can offer to the social prescribing model, but we don't socially prescribe ourselves, and that's reflected in the paper. I'll be happy to hand over to my colleague to the right if I need to answer any other questions on that, Chair, but bearing in mind we need to keep it brief, I'll move on. Thank you.
Thank you. Okay, so did you want to say anything, John? No?
I think the key point is there's some crossover with what we're trying to do with supported communities and social prescribing as a whole. Paul's right, there's a disparity, I suppose. Different practices, different PCNs deal with social prescribing in slightly different ways, which makes it more difficult for us to kind of work with them. But there's certainly an aspiration on our part to do that, and we will quite happily do that moving forward. I won't say any more than that. I know time's a bit short.
Thank you. So I think the questions for committee really are, do we see this as a major opportunity and to meet capacity and individual need? And in which case, if that is the case, where would we like to see that going towards based on the issues that people have indicated? Sorry, Charlotte.
My concern, Chair, is that the impact of social prescribing is not measured. And we know, don't we, that if it's not measured, then it's not likely to be funded. And that's my concern, is it's sort of out there and it certainly has benefits. But if we're not measuring the benefits, whether it be in terms of workload on GPs, reducing their workload, or the impact on the individual, then there's very little to demonstrate that it should be properly funded. And the very fact that these roles are unlikely to have an increased budget from April, and the fact that the management fees have not increased for 5 years, indicates to me that unless that we can actually measure social prescribing and its positive impact, then it won't be something which will be properly funded in the future.
Thank you. Can I just ask of our guests, do you indicate that you want to speak on it? I don't want to keep going around every 5 minutes because otherwise we will be here till tomorrow afternoon. Sarah.
Yeah, we can't control what NHS England does in terms of whether it increases the budgets or not. However, additional roles reimbursement schemes have been determined as permanent now. So the NHS England have said that PCNs can now employ their additional roles on a permanent perspective. And also, like I just mentioned, that the NHS long-term plan actually indicates that it wants 9,000 of these posts in England by 2036. But I absolutely fully recognise what you're saying about outcomes, and we do need to better collect that from across Staffordshire to understand what that outcome looks like anyway, regardless of whether these roles carry on or not.
Gary.
Thank you. Yeah. So whilst it would be true to say that on an individual patient-by-patient basis in Staffordshire, we don't track all of the outcomes for all individuals, we do undertake, I suppose you might say, almost like a spot check, in that we undertake things like case studies that do a more in-depth study and a narrative of individual patients, albeit you might argue that that's not independent because it's sort of selected by the worker. What I would say is, and if councillors are interested, there is a body called the National Academy of Social Prescribing, NASP. It has a very good page on evidence, which collates together several dozen studies that have been done nationally and internationally. And in fact, the evidence base there is really quite strong. So some of the stats off the top of my head, some of the studies that have been done, including one in our neighbouring county in Shropshire, will show things like a 40% reduction in primary care appointments from a socially prescribed cohort compared to a control cohort. There's equal sort of studies and stats around reduction in A&E attendances. So actually nationally and internationally there's quite a good evidence base, but it's a bit harder to track on a patient-by-patient basis locally. Just on the financing, I think where there's a particular frustration is that there has been an increase in the equivalent NHS banding in each and every year of the last 5 years. So it has been deemed appropriate by NHS England that the employees, those people who are directly employed in those roles, should have a pay rise in each year, and that can be passed on to the employees in the voluntary sector. But it is assumed that the management overhead that is absorbed by the voluntary organisation that's hosting that employee did not need to increase, which implies that everybody else in the voluntary sector didn't need to get a pay rise during those 5 years, the line managers, the governance support, and so on and so forth. So I think it's probably more reflective of an attitude that it's okay to squeeze more out of the voluntary sector. And if I compare it, it's 7% is the fee that's given. Now, we would typically seek a fee of 20%, and that would be a kind of industry standard, and that is what we would usually get through local contracts and agreements, lottery, local authority. They're amongst our worst performing in terms of finances contracts, and a number of providers have therefore handed them back nationally. There is a big risk in this that the partnership breaks down because of that lack of recognition of the financial value.
Thank you. We should note that. I've got, I should have noted who asked the question in the first place. Charlotte, did you want to come back on any of that? Sorry. Thank you. Janice.
Yeah, it sort of brings in part of what we've already been discussing in other elements today. For me, those metrics are absolutely essential for when we measure, not least because in certain aspects that I've been involved in the past, and it's one of the factors on here about housing and homelessness, is how they can vary between different local authorities, different district councils especially, and I think that's how we get to see where those benchmarks are being set for some of those. So I think that's absolutely fundamental to what we need. And I think this is providing a valuable service. We can see that in the case studies. If I could just ask one specific question, there's a reference in there about Health Inequalities Improvement Dashboard. And I just wondered who actually has access to that and can draw on that information, not least for this, but for other aspects as well.
Thank you. Who wants to pick that one up?
Is that in my paper? Yeah. Okay, we'll pick that up and see if we can allow access.
Yeah, and let's tie that to the JSNA discussion, because there will be some work from Claire McIver coming through very shortly with the JSNA, and it would make more sense to link the two together, notwithstanding the point that Janice has made. It's just otherwise it'll get ignored, one set will get lost.
It was just out of curiosity, so who actually has access? I wasn't asking myself.
Oh, it's coming. Don't worry, it's coming. Keith.
Thank you, Chair. This sort of harks back a little bit for me for the training day we had last week, at which you were at, where we were presented with information around the 0 to 4 children in care and everything else like that, and the impact that would have. And there's no financial impact. There was no concept of whether or not we're doing something right, and therefore reducing the number of appointments, for example, at GPs would be one example of today from social prescribing doing its work. I do think we're in the infancy of trying to find out what are we trying to achieve by this, and how are we going to financially measure it. I think the idea of having sort of specific objectives in some of these areas is something that we probably need to work on. But it is something that I think we need to see what the impact is, rather than just taking it at purely financial upfront payments and all the rest of it. Not obviously, I do agree with you that it's sometimes undervalued from what I've seen across my division. But I do think that we do need to have a discussion about this at some level, because it's different groups working together, providing the services or being contracted to do the services without understanding quite what the impact is, and for the reason we understand but the impact we don't at the moment. So I think that's something that could we note that for future, so you can try and look at that across several of the voluntary sectors and services that they are providing at the moment, because there's still not what I'm doing. A dashboard for voluntary services doesn't exist from what I can work out at the moment. Thank you.
I mean, clearly this committee can make recommendations, and that's probably where we're going towards. And so do we, and I don't think there's any question, and Gary's point is exactly right, I don't think there's any question that social prescribing works. And there's plenty of case studies, including it in this pack, that demonstrate that. It's a bit like Housing First was originally in homelessness. There's plenty of evidence, nationally and internationally. And let's go from there. We've not really touched any questions in terms of what our feeling as a committee is on the opportunities for greater collaboration. It seems to me that there are many disparate parts trying to do similar things, and we haven't broadly brought the Midlands Partnership Foundation Trust here today, but you remember that one of their key objectives, stated aims, is to have greater earlier intervention and do more community focus work. And one of the reasons for bringing the three parties together in the same place, and I'm sure they thank me for this, or thank committee for it even, was really to try and shine a spotlight on this, because if there is greater collaboration, maybe we'll make the work money that is sitting, that people are putting into the voluntary sector, make it go a bit further, or pick up some of the issues that Gary talks about. And that was probably as much, and the funding, actually, money will follow the results, which I think is the points that people have made earlier. Does anyone want?
Sorry, Chair, just saying, if we can measure it, we can know what the impact is, then the funding should follow, because then it will make more sense than just having this idea at the moment that it is doing some good. I'm not saying that it's not doing a lot of good. I'm just saying that at the moment there's no meat on the bones, as it were. We need to understand a bit more about something.
Just in the use of best time, because we're coming up against 1 o'clock. So I think we've got a clear recommendation in terms of data. Do we have any feeling in terms of a recommendation in terms of the opportunity for greater collaboration? There was at least 2 papers which suggested there was opportunities for greater collaboration. Do we want to pick that comment up? And thirdly, Keith, you mentioned the community event last week. It strikes me that Victoria Wilson, as the Cabinet Member for Communities, is doing a consultation at the moment, and maybe we send her the whole lot. Sorry, Keith, do you want to put your mic on?
Well, we're working on the community strategy as well, and all that is part of that as well, aren't we? So it's what you just going about to say, I think, wouldn't you? No, you said it, right.
Okay, I think there's three recommendations, a bit of a messy bundle. First recommendation is just a request from all parties to come up with a strategy to collect data better. If it strikes me if the Mercian region can do it, then actually there's a template to do it there, but don't let us prescribe the answer. But greater data collection. Second of all, greater collaboration between all parties and greater visibility of each other's initiatives, because maybe there isn't collaboration, maybe it's just greater visibility. And thirdly, to send the papers and our recommendations to Victoria Wilson as part of her consultation. Is that what committee wants to do? Thank you. I hope that's okay. Right, ladies and gents, our guests, thank you for coming. Thanking you for sticking right the way through. Can we move on to the next agenda item really rapidly? Item 8, please. Can I make just a couple of comments on this? First of all, we've talked about JSNA, Joint Strategic Needs Assessment, which is broadly some localised data that is being refreshed, which will be available to districts and boroughs. Really help you or districts and boroughs drive the agenda that you want to drive. That is coming to committee. We had the conversation Friday. When was it? Oh, okay. That's why I don't remember it, because it's to be confirmed. I think this will be in the summer. We can then use the data that Sarah's been talking about as well and overlay some of that, and it can help drive activity locally in a focused way. That's the first thing I'd like just to make you aware of. Second of all, the chair of the Safeguarding Committee at the county is planning to write to all districts and boroughs about vaping and his concerns, or the committee's concerns about vaping. I don't know the specific context of the letter. I've not seen it myself, but I just wanted to highlight to you that it's coming either to your cabinet members or to yourselves, I don't know what the vaping strategy looks like, but that may be something that you may want to have a discussion on locally and then bring back here. And then the final bit, and it's referred to in the Lichfield papers, the South Staffs papers, there is, and you may not be aware of this, a Health in All subgroup as part of the Leaders Board. And all of your officers at a senior level, at a district and borough level, are doing some work on health inequalities and health in all. And you may want to acquaint yourselves with that work, or even as part of your scrutiny agenda, you may want to just identify what that work is so that there is a member input to that initiative. And I understand there is funding from the County Council towards that, and I would really encourage districts and boroughs to pick that up. Can I just go around the room and just see whether anyone wants to add anything in terms of what's on the agenda here? No, I'll just ask on one thing that Zach goes back to Newcastle and lets them know that dentistry is a county issue and not a local issue. And I would just remind committee members that if you want to understand the difference, then there is a set of terms of reference, and I would encourage you to try and encourage your members to read them and then stick with them. Final bit is the forward agenda. I would suggest here that we would be wise to create some of the draft plan for next year. We can't determine what the next committee is going to do or determine their own priorities, but I do think you would get rid of this cliff edge if we started pulling together a draft plan with committee's permission, and then whoever is on the committee can make that decision once we get there. Are we happy with that proposal? Are we happy with the proposed agendas going forwards? I would highlight there is a mental health set of site visits, but we are limited in numbers. Does anyone else want to raise anything else? We will send you the calendar of meeting dates for diary management purposes. I'm not suggesting you will be on this committee. I'm not even suggesting I'll be on this committee. But maybe it'll help with your diary management, and because you can always take them out rather than anything else. And we also need to add for scrutiny quality accounts and the provider trust reviews that will come through in the spring, summer. Anyone want to raise anything else? Otherwise, I will wish you a great afternoon. Thank you for a really lively debate this morning. I thought that was a really useful set of scrutiny, so thank you for all your involvement and engagement. And at 1 o'clock, you've done brilliantly to get in at 1 o'clock. Have a great afternoon.